Live.
Just 2 seconds.
Thank you. Good morning, everybody. Can I welcome you to this meeting of People and Health Scrutiny on Monday, the 17th of November. I'm Councillor Tony Coombs, the current chair of this committee. I won't do full introductions, but if everyone could introduce themselves when they speak for the first time on each item, that way anybody listening in will see who you are. But I will introduce my vice chairman, Councillor Jane Somfer.
Morning, everyone. Could I just say, if you have a question to ask through the chair, if you could just indicate to me so I can make a note. Thank you.
There's only so many picks I can spin at any one time. So when you do say who you are, can you also remember to say which ward you represent? I should say that I represent Verwood Ward, because I always forget. Anthony, do we have any apologies for absence this morning?
We have apologies of absence from councillors Robin Legg and Barry Gorringe.
Lovely, thank you. And everybody else is here. So moving on, more housekeeping. Are there any declarations of interest by any member of the committee?
Rather than the way we're getting
child within the HCP.
If anything does come up during the discussion, then highlight it as and when you become aware, and we will deal with it appropriately at that point. You have the minutes of our previous meeting, which was held on the 22nd of September. Are you happy that they are an accurate record of that meeting?
Agreed.
Yes, agreed. I'll sign them at the end of the meeting. Okay. So moving on to public participation, we have no members of the public, and we have no questions from members, and we have no urgent items. That takes us quite swiftly on to the main substance of the agenda, and items 8 and 7 are both deep dives into adult services. You'll have noticed when you read the reports that the wording actually sends them the other way around. So I'm going to take item 8 before item 7. I think I need to just make people aware that we are expecting some IT updates and things happening this morning. As you can see, that's happened next door already. So hopefully it won't interrupt you too long, but if there is an issue, can you wave at Anthony and he'll get somebody from IT down to try and sort it out quickly so it doesn't interrupt our flow of work. Okay, so sorry about that. Julia, good morning. And Jonathan, good morning.
Good morning. Hi, I'm John Price. I'm the Exec Director for Adults, Health and Housing. So we've got a couple of reports here today. I just wanted to say at the start, thank you for accommodating us on the agenda. We do have CQC coming, and obviously that's those dates are subject to CQC's notification, so they are coming week of the 8th of December, and therefore a really good opportunity for us to come today to talk about some of our weights and some of our carers' work and the journey that the directorate's been on. So I'm really pleased to introduce Julia Ingram, who's in the room, to take you through this, and hopefully we can pick up questions at the end. Julia, can I hand over to you, please?
My name's Julia Ingram, and I'm the Corporate Director for Operational Adult Social Care. And it seems very appropriate that we've been invited to do these 2 deep dives this week, because it's National Safeguarding Week this week, and you've got some safeguarding data in the report and a presentation from the Safeguarding Adult Board later. But it's also National Carers' Rights Day on the 20th of November. So this is a form of celebration for both those events. Before we start, talking about waiting lists. Nobody wants waiting lists. It is not appropriate for us to leave people in need of care and support or in at risk of harm through a safeguarding or a deprivation of liberty safeguard for them to be on a waiting list. And we've been extremely congruent of this fact for a number of years. COVID has had a significant impact nationally on waiting lists. There was a change in legal expectations during the COVID period, which asked local authorities to step in and support more privately funded people than we would normally routinely do. And that has left us with a legacy of waiting lists that we are working actively to reduce. So what I will be doing is talking to you a bit about where we're on that journey. We've had a very targeted approach to most of our waiting lists from 2024. And so what I will be doing is describing some of the progress against that. And I'm going to take you through a slide deck that will supplement the written report you've got and hopefully give you a bit more detail, both in terms of current numbers, because numbers change every day on waiting lists. New people come on, other people move off. So I wanted today to share with you the most up-to-date information. I have the next slide. So really just to set the context, in Dorset, 30% of our population is over 65, and the national percentage is 18. And in a moment, I'll explain to you why that's relevant for our waiting lists. That means in the west and the east of the council area, 1 in 3 people will be over 65. 20% of Dorset's population have a health condition that limits their day-to-day activity compared to 18% nationally. That again impacts on both adult social care, but the population as a whole. In the last 12 months, our contact numbers, so that's people who've approached adult social care for care and support, it has been 21,670, and that's up from 19,848 from 23-24, and that's an upward and consistent trend over the last few years. Safeguarding to date, we have had 4,736 safeguarding concerns raised with us, and we're only on Q3 of our report. So that's 7% up on the total number that we received last year. Our deprivation of liberty safeguarding referrals last year, in the last 12 months, is up 13% on the previous years, and that's against a national average of 11%. In the 2021 census, Dorset residents declared themselves as carers. That was 35,505 people identified themselves as carers. And we know that's a hidden figure, that there are significantly higher numbers of people who provide carers support, but they're notoriously bad at identifying that. People see caring responsibilities as just family responsibilities, so rarely declare their needs. And carer referrals for Care Act assessments in the last 12 months reached 853. And I'll describe a little bit more as we go through this about what the difference is between those different kinds of assessments. Can I have the next slide, please, Tony? Now, why do I make a point about the age demographics? I've got Councillor Robinson on my left,
who is old,
who will always champion the value of what older people can do. And as I sat next to my 91-year-old mum yesterday, as she read the readings in church, I can absolutely advocate what a significant contribution older people make to the community in Dorset. But I would also want to indicate that having such a high over 65 population does mean a significantly higher number of people approach the council and draw on support or need to use some of our key services. So 74% of all of the contacts we received, so that big number of 21,000, were for people over the age of 65. Our adult access team is incredible in the work they do, and they actually resolved of that high contact number 75% at the point of contact, which means that 75% of the population have their solutions solved as close to the point of contact and as close as to their need as they have to. But the remainder come through because it's been identified that they have an issue which only the local authority can resolve through some form of complex assessment. 80% of the people who come through for a Care Act assessment are over 65, but only 63% of the people with funded care are over 65. And that is because we assess through some of our legal frameworks a high number of people who fund their own care. And so that's why you've got a difference between the percentage of people we assess and the percentage of people we fund. So through our safeguarding responsibilities, through our deprivation of liberty safeguard responsibilities, through things like Section 117 responsibilities, we are responsible for assessing people who fund their own care. And the Care Act expects us to offer anyone who approaches us for an assessment irrespective of whether or not they end up being funded by the local authority. So that's why you have that slight disparity in the figures. 69% of the people with a safeguarding referral were over the age of 65. 66% of all carers assessments are for people over 65. And I wanted to draw your attention to the fact that we have over 107 people we assessed last year who were over 85 years of age. And 93% of all of the deprivation of liberty safeguard applications are for people over the age of 65. And that's largely because that's a community of people in residential and nursing care placements. And as I say, it includes a large part of the private community that we support by checking that the restrictions that are placed around them when they're in a care setting are lawful and proportionate to their right to liberty. Next slide, please. Now, this is some of the current data and detail about our waiting lists. The little chart on the top, it is very small, I appreciate that, but I wanted you to see the trends. It starts in 2024 and shows the impact of our interventions to reduce our waiting lists over the last few months. There's a huge amount of additional work that we have to do, but we have worked consistently and hard to try and reduce that waiting list. So for safeguarding, so far this year, we've had 4,736 contacts. Some of these figures change slightly, and I apologise for that. That's because I've written this report in various stages over the week, and figures do change. But at the same point last year, we had 2,432. 15% of all of the safeguarding concerns that we are approached about go forward to what they call a Section 42.2 inquiry. That indicates that someone is at risk of harm, and we are required then to instigate an investigation, an inquiry into the risks that they're exposed to and to mitigate those risks. We don't have to do those inquiries ourselves, but it's the local authority's responsibility to make sure that those inquiries are undertaken. We triage all safeguarding referrals at the point of contact, and we have no one waiting for a safeguarding concern to be triaged. That means we understand the risks for everyone who comes through, and we prioritise on a basis of risk. There are 18 Section 42.2 inquiries waiting to be allocated, and that's not an acceptable number, but it is a significant improvement on where we were at the beginning of 2024 when we had 239. So as you would expect, we have prioritised assessing and moving forward the work to protect our most vulnerable people. And this has included diverting resources away from other parts of the service where there is less risk to make sure that we look at this area. And there are two areas where we have limited control over the volume of work that comes through. Safeguarding is one of those areas, and the other is deprivation of liberties safeguards. Assessments in the last 12 months, these are Care Act assessments, so either an assessment for a strength and needs assessment or an occupational therapy assessments. And we have, the headline figure is just to let you know that we currently fund 4,423 people through the local authority. We completed in the last 12 months 3,300, I'm trying to read the figures from a distance. Tricky. I'm going to get my bill of paper out. 3,390 assessments were completed, and we completed 5,311 reviews of people's needs. So that's people who are currently receiving care and support, and that's the number of people we reviewed. We've currently got 216 people waiting for a Care Act assessment, but that is a 40% reduction on the waiting list position we had at the beginning of 2024. Again, that's too many people than I'm comfortable with, but you will see in a minute some of the work we're doing to mitigate that and reduce that. Again, those assessments are risk assessed when they come in, and people are allocated for assessment on the basis of the risks that they are exposed to. You can see that we undertook 1,951 occupational therapy assessments last year and 1,950 reviews for an occupational therapist. We have 107 OT assessments waiting, but again, this is a 45% reduction in the total number of waiting occupational therapy assessments that we've had waiting. In the last 12 months, we undertook 702 carers assessments, and 77% were carers assessments on their own. What I mean by that is that under the Care Act, we are able to assess a carer in their own right, or we can assess them jointly with the cared for person. And in Dorset, 70% of all of the carers assessments that we looked at were for people in their own right, and 23% were for people jointly with the person they cared for. 625 reviews were completed for carers, and 95 assessments are still waiting to be allocated. And again, in a moment, I'll share with you more. Well, later on in the second presentation, I'll share with you more of the work that we're doing around carers and how we're supporting carers outside of a Care Act assessment when you consider those very large numbers. In the last 12 months, we have had 3,992 applications for deprivations of liberty safeguards. And as I said earlier, that's a 13% increase in demand compared to the national average of 11%. We've done a lot of research looking at our neighbour local authorities and looking at other local authorities nationally. And although that the number of people waiting for a deprivation of liberty safeguard to be authorised is high, because of our over 65 population, we have a higher percentage of people applying to us. And so when you look at our data compared to the national data, we are very much in the mix, if not good, in our performance. There are 69 people who we would consider to be priority dolls. So those will be people where the restrictions are considerable, where they are objecting to the restrictions in place, or where we have a court of protection process. We are still waiting to allocate those. And again, we've had a significant improvement in the oldest or the length of time people have been waiting for a deprivation of liberty to be assessed. I have the next slide, Anthony. So what are we doing to improve things? We recognise that if we don't provide better solutions to people at the point of contact, then there is a risk because of the expected growth in demand, particularly from our older population, but not limited to that, because we've seen an increase in the number of people coming through to us with complex mental health problems and with learning disability, that if we don't manage our front door more effectively, we will really struggle to manage our waiting lists. So as part of an adult social care operations redesign over the last year and a half, we have significantly improved the information, advice and guidance that's available to people at the front door. Why is that relevant? Well, it goes back to that figure at the beginning. If you consider that we managed to provide solutions to people for 75% of the inquiries, then the more information we can give people in the communities in which they live, the less people will need to come through to us to have answers solved that actually they could have resolved themselves. So on that slide, I share some of the initiatives. We've now got QR codes in the GP practices on their screens, which directly link people to the information and advice on our websites. We've also got postcards that are available in the libraries and in other resources that, again, provide people with QR codes and direct access into the websites that we've got. And our libraries provide direct resources and information and advice and guidance to customers who come through there. We've got a cost calculator on the intranet now that helps people to get an estimate about the amount of care that the cost of the care that the person they look after or they may themselves require. That allows for two functions. One, it helps people who fund their own care to understand what it might cost for a package of care. But for people where the local authority fund, it gives them an indication of what kind of charge they might have for their contribution to care. Because in adult social care, people are means tested and will have pay a contribution towards the cost of receiving the care and support. The impact of all of that, it means that we get to people early, supporting in prevention and giving them clear information and advice. If people then come through to the adult access team, then that's a team that's staffed by social workers, occupational therapists, and by assessment support coordinators who are all skilled and experts in adult social care. And we launched in October a really exciting new initiative called the Prevention and Early Intervention Team, and that's heavily loaded with occupational therapists and linked to a community-based reablement offer. What that means is that if it is clear someone is struggling to manage their personal care, we are now able to go out to assess them and provide them with up to 6 weeks worth of reablement to rebalance them. If we follow the national trends, that means that a significant proportion of those individuals will not, at the end of that reablement, in fact, need ongoing care and support, but will be then rebalanced and able to manage their lives. That's linked to a really important offer of technology and equipment and linked to our independent living centres. The idea being if it's therapy led, then we've got a really strong focus on prevention and reablement and helping people to solve their own care and support needs. The current performance, as I say, at Adult Access Team is 75%. We're hoping that the introduction of Prevention and Early Intervention Team may further reduce the number of Care Act assessments coming through by a further 35%. So that's 35% of the people who currently we identify as needing a care and support plan may no longer need that if we get the reablement offer for them. Right. Next slide, please. Now, obviously, we're not satisfied with people sitting on a waiting list. So as you would anticipate, we have taken measures in all of our key areas to make sure that people have, that we have proactive approaches to managing people's well-beings on the waiting lists. We use the ADAS, that's the Association of Directors of Adult Social Services, task force screening tool to support the management and prioritisation of any deprivation of liberty safeguarding. We use our dashboard to track individuals and we commission additional support from independent best interest assessors to help us to manage our demand. I've talked already about the early intervention and prevention service and some of the actions we're taking there to reduce our waiting list increasing. One of the things that I haven't described to you yet is that we also support a cohort of people who have what is known as Section 117 aftercare needs. These are individuals who've been assessed under the Mental Health Act and require support on discharge. Of that population, we have assessed over 206 people last year. We've provided over 276 aftercare plans, and we've conducted over 296 reviews. Those are people who are detained under the Mental Health Act, and there are joint responsibilities across the NHS and the local authority to make sure that their needs are met. We also have a significant complexity in the work we do. We currently have 45 cases that are being worked through with the Court of Protection. 15 of those are welfare concerns, and 30 of those come under what they call Section 21A referrals. These are people who lack capacity to make decisions for themselves, and where we need the guidance and the decision making of the Court of Protection to determine the right outcome for them. We're currently working on evidence for 3 inquests where we are required to give evidence. We have 5 nearest relative applications that are underway, 10 considerations under ordinary residence rules where we are in dispute with other local authorities about who are the responsible local authority for delivering care. And we have 90 community DOLS applications for people who are over the age of 18 and 6 community DOLS applications for people aged 16 to 18. I'm using those as examples of some of the additional complexity that sits in the work that we do at the moment. We've also identified and built a risk management tool and guidance to facilitate people waiting well. Obviously, if we have people on a waiting list, we need to make sure that they do not deteriorate. So we do regular checks. Frontline teams will regularly check their well-being. We undertook some research a couple of years ago that identified that people are at risk of falls if they remain on a waiting list for any period of time. That's clearly not good for them. It's also not good for the health and social care system, as there's an increased likelihood of people being admitted to hospital if they fall. So one of the other initiatives is we've increased our work as part of our partnership with the NHS and public health to look at how we pick up people at risk of fall earlier and improve our falls offer to the communities. I think that is probably all I wanted to say.
Well done, Julia.
In terms of supplementary information, I have a gang with me of experts, and so we are ready where we can to answer any questions you might have. And obviously, if you ask a question that we can't answer now, then we will take note of that and get a response to you. Chair, I hope that was helpful.
That's very helpful, thank you. Before we move into the committee, Steve, as Cabinet Member, did you want to add anything at this point?
Other than to say thank you very much for adjusting the agenda to accommodate today, and just to re-emphasise what Julie said at the start, no, it's not acceptable for anyone to be left waiting. But the steps that the council has taken over the past few years have gone hugely towards mitigating that, and the future is looking quite good. Based on the information that we've got at the moment. Thank you.
One of the things that I picked up was you talked a lot about the reduction of numbers on the waiting list, but I didn't recall hearing anything about the amount of time people are sat on those waiting lists. Did I miss it, or is it something we need to add in? Because obviously that's an important factor, isn't it?
No, it is. It is a really important factor, and we have one or two elements which affect the average waiting list time. So we currently accept referrals for people on birth to settled adulthood from the age of 14. And we have a legacy cohort of people who we had a Care Act assessment referral in 2014, where at the age, no, not in 2014, at the age of 14, where it would not have been appropriate to undertake a Care Act assessment at that time. But the clock ticks from the point at which we get that contact. So the longest wait we have is actually over 1,000 days, but it is for someone who was 14 at the point of referral. What we've subsequently done is introduced a new assessment tool, which allows us to do a preliminary assessment when someone is aged 14, and then trigger a Care Act assessment at a more appropriate time.
And what about the over 65s? What about the over 65s?
I'm going to ask Eleanor, who's got the most recent data and is our lead in localities, to confirm the over 65 data.
If you 2 seconds, because I pulled off the data this morning as part of the data cleansing work that I do with the teams. So I'm Eleanor, I'm the service lead for localities. So our over 65, our longest open assessment is 230 days. However, that is allocated to a worker. So our longest where someone is waiting for allocation is 119 days. So that's less than 3, just over 3 months.
And you can see why the waiting well then becomes very relevant, because we would not want people to deteriorate without us being aware and in constant contact with.
And to help put that into context of where we are now compared to where we were. So 18 months ago, we had 196 people open over 7 months who were waiting for an assessment to be completed, and that number is now 19. And we had 186 between 4 to 6 months, and that number is now at just under 50. So we've made considerable impact on those longest waits of people.
And that's equally as important, isn't it, as the number of people on the waiting list. You've got to balance the two. If you've got a long waiting list, but people are moving through quickly, it's not as serious. But if you've got long waiting times and long waiting lists, then you've got a real problem. Yeah. Absolutely. So I've now got sort of a queue of members. Carol, you're up first, and then Andy afterwards.
Carol Jones, Sturminster Newton. I sort of want to go into a few different areas, so bear with me. First of all, I just wonder whether there is any real differentiation between locality. Is there a locality that is more problematic with higher numbers at all? Is that something you know, Eleanor?
It's really hard to weigh up the difference between the localities due to the size, the makeup of the complexity of work. So, and they all have different challenges. So it's really hard to then say whether there is any that are specifically working better or worse than others, just because we have such different cohorts coming through each area that it's hard to kind of compare and contrast across.
If you were going to look just at numbers,
Yeah,
the East has the highest waiting list, but the East has the highest volume of people coming through for contacts and referrals. So what we then have to look at is what proportion of their contacts do they complete? And actually they complete a good percentage of their contacts. They are they work well with people. They do the highest number of assessments, and so the figures, the high level numbers, don't always tell the detail that sits behind it.
okay. And then in terms of the 70, I think you said it was 74% are dealt with at the point of contact. What sort of issues are they coming through to Dorset Council with? Because I'm just concerned that these are probably things that we should be able to do better in our communities. So what sort of areas are they coming through that they're able to be resolved straight away? What are they talking about? What are they needing?
It's huge. It's a vast area. So it could be someone, for example, who's at has concerns about a neighbour who's got mental health problems.
Right.
And it may be that the AAT's first response is then to refer them to the GP and connect him with the GP practice. So that wouldn't then be something that we would take on, because the referral route for our mental health clients is through those GP routes. Sometimes it's people simply not knowing how to navigate, for example, the intranet, because they may not be confident and literate about using that. So they would come through and have a conversation about what advice and information was available. A significant part of the work we sort at the front door is occupational therapy solutions. We can start putting in equipment, but the front door team can commission the equipment from that point. So it would be that. It can be anything from support around meals, hot meal preparation, where someone doesn't have any other greater need, but they might want to know where to get a hot meal. So it really is a vast array of issues. If you would like me to look at some detail and provide you with...
Yeah, I'm just wondering what we can do better in our communities. And I wonder whether it might even be possible for us to look at some sort of drop-in facility, perhaps at family hubs or in a location in each area. But because I think that could be quite interesting. And it's something I think that perhaps the communities can help more with, that might ease the pressure.
So John Price has popped his hand up immediately to come in.
John, darling, come on in, come.
Yeah,
The chair, sorry.
Is that okay to come? Yeah, there's such a big opportunity here, councillor, and you know what we're already doing in some of those areas. You know, through largely the children's footprint is very impressive. I think that the work we will be doing, we'll be looking to kind of level that out across over the next 12 months. So it is a really big opportunity, and we can already see, I'm sure, you know, some of the data Julie might pull out shows the really positive impact that the community is having in supporting the community. But there's a lot more that we can do in that space. It's really a great opportunity. It's one of our biggest assets in this area, so one we want to build on.
So I think there is some confusion in terms of the different strands of work. So I was in on a meeting with Thriving Communities, which is all about stuff going on in the community to, you know, with the prevent thing. But then I'm not sure where that fits with integrated neighbourhood teams, and that seems to have died a bit. So I don't know. I think there is still some confusion amongst all of these different strands. And before I go completely, one more, I'm just wanting to be clear, where does health come into this, and who is actually, are you doing all of the care assessments, or is that sort of put through health as well? I was just trying to see where both come together, and is there a disparity and a bit of silo working that's still going on in health?
So can I get John to answer the first bit, and then I'll come in?
Sorry, I didn't remember what I said now.
Thanks, Julia. So it is quite complicated, but I think what we could do is do a briefing on that. I mean, obviously, the neighbourhood health pilot being agreed for the West is quite significant, and working with Sam Crow, we're looking to pull all of that together. But there are bits that are happening at different speeds and different agendas. So largely we're talking about the agenda that the council's driven through over recent years in terms of the reform in adult social care, but obviously that reform in the health system is coming through their 10-year plan as well. So we're aligning all of that work at the moment, but they often are working in the same spaces and to create the same outcomes. there's a piece coming later on the agenda around future care, which I think is another strand of this, but it'd probably be quite helpful if we brought some of that in the coming months, just to explain how all these bits do fit together. But I'll let Julia answer the second part of the question. Thanks.
So most of the assessments I've described to you this morning are the responsibility of the local authority to undertake. So the Care Act sets out our statutory responsibilities in terms of assessing people who might be in need of care and support. There are places where we have joint responsibilities with the NHS. The obvious place is the Section 117 assessments that I mentioned earlier, where it's set out in law that if someone is detained under Section 3 and has support needs to keep them out of an acute mental hospital again, then it's the responsibility of both the local authority and the NHS to pull together with that individual what they call an aftercare plan. So that's a shared responsibility. We also have spaces around continuing healthcare and joint funding, where the local authority and the NHS would work closely to determine if somebody had primary health needs. The final decision maker is the NHS, but the local authority is required and actively identifies where the local authority legal limits lie. So where does our responsibility as determined by the Care Act stop? And what's our rationale then for arguing that somebody might have primary health needs? So we have to work really closely with partners in that space. Hospital discharges, where you will hear later on in a presentation on future care much more about where we work in partnership in those places to assess people's needs. But the framework in terms of the local authority's enduring responsibility still sits within the Care Act. And that's the legal framework that we use to determine. In areas such as the Mental Health Act, we jointly assess. So if we were doing an assessment under the Mental Health Act, then that requires what they call Section 12 doctors, so 2 doctors and an approved mental health practitioner to determine if someone should be detained under the Mental Health Act. So there are spaces where we really clearly work with health. But the bulk of the work I've described this morning, and where CQC primarily will examine us, will be on those assessments where we're the lead organisation. And under safeguarding, under the Care Act, the local authority has the lead responsibility for ensuring people's at risk of harm or abuse have their safeguarding needs understood.
No, thank you. My very final question: are you fully staffed, or do you have staffing vacancies that means that you're not able to complete all the inspections that you would like to?
So Dorset has a retention level of about 11% at the moment, which is actually quite good against the national average and good against Dorset Council's retention rate as a whole. Our areas of challenge are in getting experienced social workers. So yes, I have vacancies, and the vacancies are in those more experienced social work and occupational therapy roles. What we're doing currently is we're doing a large piece of work as part of our redesign to examine actually what are the skills we need moving forward in social care, because the work is changing. It's definitely becoming more complex. And the point you made about if we're able to help people more in the communities, then the work that comes to the local authority will only get increasingly complex. So we need to make sure that we have people with the right skills. So we've done a lot of work around self-neglect, around substance misuse. We're working really closely in partnership with colleagues in housing and our colleagues in commissioning to identify where those trends are, and we're doing a piece of work using the data that we've got about the Dorset population and the people who come through to us to understand where that complexity sits. So how many people do we have with Mental Capacity Act assessments? How many people do we have where we've got MARMs, multi-agency risk management meetings? Where are they sitting? Which teams are they in? What are their primary support needs? So that we can then look at where do we need to use our resources to the greatest effect. And we're doing that redesign work over the next few months to try and make sure we increase that. And if I go back to, I can't currently control the safeguarding referrals number. We can't currently control the deprivation of liberty safeguard numbers. So I know we need to divert resources into those spaces, but I need to therefore manage the demand coming in elsewhere, which is why we're really investing in our front door, because that's somewhere where we can make a huge difference to the outcomes of people in Dorset, but also make sure that then we've got the right resources in our community and our specialist teams to do that complex work in the future.
Thank you. Thank you, Chair.
I'm going to move this on now. Thank you. Andy.
Councillor Andy Todd, Coalhill, Minster East. I fear I may be overlapping a bit with what Carol just said. I apologise, Chair, in advance. Stop me if I'm. Drag you all the way back to the start of your presentation, and thank you for that, if I may. You mentioned a reduction in waiting lists. Can you give me a bit more context? Was the previous year that there was a reduction against an outlier year? I don't have the background experience to know this. Was it a particularly high year? Was it a low year? Have you applied a significant increase in staff in order to address the waiting lists? Is this a normal level now, or are you looking to throttle the amount of work that's going to be going on? So we're going to see a stabilisation in the size of the waiting list going forward, or is it going to go up or come down a little bit further? And how does that perform against statutory obligations that we might have?
Do my best. So I think there's a combination of things going on, and our colleagues will step in and correct me or supplement. So I think we've got a combination of things going on. Definitely a legacy from COVID, which gave us a waiting list backlog that we have taken time to navigate and to reduce. But we've got that increase in demand that's clear. So if I take you back to one of the earlier numbers that we have got in 2023-24, we had 19,848 contacts to us, and we've had just under we've had 21,200, and if I project forward, we expect to be over 22,000 contacts by the end of the financial year. So you've got that growth and a legacy.
May I just interject, Chair? Is that a real increase, or is this greater ability for people to get in contact? So the demand may always be the same, but you just make it easier for people to get in touch with you.
That's a really interesting question, and I don't think we've examined that in totality. So we will go away and look at that. What we absolutely have is an increase in our over 65 population and an increase in the number of people who are coming through requesting support around mental health needs. Now that's a national trend and a post-COVID trend, and a trend in our under 18s that are coming through birth to settled adulthood. So my hypothesis would be that it's a combination of all of those things, but inevitably, if you put more information out to people, more people are likely to come, and we think that that's the reality of safeguarding, for example.
Yeah.
Do you want to come in?
Yeah, I mean, I think
Before you
so.
do, sorry.
Jonathan to come in.
Oh, sorry, John.
Yes, so just to supplement, I mean, what we can see is year-on-year increases in most demand lines. So, you know, we've certainly got increasing demand. At the same time, we are bringing these weights down on balance across the piece. So the conditions are increasing demand in most areas. certainly Julia's point about complexity is definitely playing out, and you know, it's a difficult and challenging journey we're on to bring these down, but I think we will see further reductions next year, but at the same time the backdrop is that increasing demand, and I think, you know, Karen's going to talk a little bit about the safeguarding element of that, and that is substantial. So I'll hand to Karen.
Jonathan. Hello, Karen Mayer, Head of Specialist Services with responsibility for adult safeguarding, mental capacity act and dole service. So I just really wanted to pick up on the point specifically around safeguarding, because in September 2024, we had a waiting list of 239 individuals, which was very uncomfortable and not a place where we wanted to be. So we've taken a really hard look at ourselves, because actually we've had a specialist model in safeguarding for about 11 years. And that has enabled us to have a central point for all concerns to come into Dorset Council. And actually we need to look at actually whether that model will still fit for the future, really. So we piloted in February of this year a hub and spoke model to move it back out into the community. So we took a walking alongside approach rather than having that specialist model, which was often the focus. And we wanted to ensure that safeguarding was everybody's business. And by changing that model and having our workers out in the communities more and working alongside community members, the person, the teams, actually we've seen a significant reduction. It's enabled us to manage our waiting list much more effectively. So I check, as you'd expect, the dashboards every single day. And today, you know, for those people that they've had their initial risk screen, but that waiting list is 13 today. So that's well over a 90% reduction in our waiting list for safeguarding. You know, since 2020 COVID, we were receiving between 70 and 80 safeguarding concerns a week. We now receive up to 120 plus a week. So we're constantly trying to manage that demand and risk screen within 24 hours. There's nobody waiting to be risk screened. Over 50% of our concerns last year, and we're heading for the same direction this year, is coming from the provider sector. So our residential nursing homes, our supported living environments and our domiciliary providers. So we've been working closely with the Dorset Care Association, and we've set up some provider webinars to really sort of support knowledge, skill, understanding, confidence for our providers. We've always had a really positive relationship with our provider market, and by having that sort of, you know, those learning sessions to build knowledge and confidence, we're supporting them to think about actually what does need to come through to us and actually what's quality, because often some of the stuff that's coming through to us is actually quality and could go down our quality and monitoring route rather than safeguarding. So we're working very closely with Tanya Dawson-Sheehan, who's head of service in our commissioning team, focusing on quality to try and support providers to make sure we're receiving the right things coming through, because we still, once they come to us, we need to obviously look at those, do some information gathering, process those, and it can detract from some of the urgent stuff that we want to be looking at. So I think we've always got more to do in safeguarding, as we have in our dole service. You know, I'm constantly using the word evolution. You know, they're very complex. They're often very tricky, difficult situations that we're supporting people with to navigate safely and get the right outcomes for them. So we will always evolve day by day, month by month, month by year, you know, year by year, to try and improve our service, you know, ensure people at the heart of those decision making to make sure that they feel safe in their community.
Question.
Thank you. Councillor Jane Sompler, Beacon Ward. Most of the questions have been asked that I had, a very long list of, but also Julia, the context of which you provided within your slides answered a lot of questions that I had, so thank you for that. I also want to thank the team for their ongoing commitment, particularly in the area of safeguarding, to those individuals who they are there to protect. And I know that it's a very complex picture, and I know you've done an awful lot of work in that. And Andy asked around, you know, why this increase, where that is coming from, and you've explained that well, and providers are really where that area is. That hasn't really changed. It's always been that way. And I know you're talking about conversations that you have with those providers around what really needs to be coming. So you're presumably going to continue having that, because I know those conversations have been going on actually for a long time, and I suspect that's about confidence within the providers. not being, it's not just about not being clear, but it's about being confident that they're making the right decisions for people within their care, because if they get it wrong, we know what the consequences of that are. So I guess it's a sort of, well, we'll just check, just for their own understanding. But outside of care of providers or care homes, you're presumably seeing some sorts of patterns coming through and increases in those areas, as well. I'm assuming. And I just wanted to ask about data cleansing. What actually does that entail, and how does that improve things? I can see how it will improve things for the service, but I'd like to know how that improves things for our residents.
So if I start with the service bit of data cleansing, and then I'll move on to the impact. So it's really important that we have accurate information to base our judgments around where we put our resources and how we support people. And we use a Mosaic client record. That's the database we use, and that's, we draw from that all these high level figures that I've shared with you today. Our frontline teams are responsible for inputting the data onto those records, and so we need to have confidence that that data is put on in the right way at the right time, that we don't, for example, have scheduled reviews put on for a future date that's not appropriate, for example. So we cleanse the data regularly to make sure that the data we work or create our activity against, or make decisions about how we're going to put our resources, is the best it can be. And why is that important for Dorset residents? Because if I'm with my team going to be allocating resources in one particular area or another, and I'm using the data and the evidence we've got on our system, and that data and evidence is not accurate, then I'm going to divert resources into the places that aren't where the greatest need is. And that may mean that I don't then provide care and support for a group of people as a priority that I should be, purely based on the fact that my evidence isn't as it should be. So I would always see data cleansing as an absolutely key part of a responsible local authority adult social care, and making sure that we then use the right information to inform us. And we've got a really strong performance team behind us who support us do that, and really good business support workers in all of our teams who help us to do those validations.
I'm going to have to move us on. We've been an hour on this paper already, and we've got a very full agenda. And you know, I'm sure you all have homes to go to, because otherwise it would be here till bedtime. It's not that we're not interested in hearing more, but it is a very full agenda. But if there's anything that any member wants to take up outside of the meeting on any of these papers, please do so. I'm sure officers will be more than willing to talk to you outside, and we can always bring something back if you want to discuss something in any depth. Moving on. So thank you for this one. If I move us on then to the deep dive into carers. Thank you, Julia. And so you're just going to copy chat for me, aren't you? Thank you. So I think we said in our introduction that unpaid carers really are the backbone of support for people in Dorset and people nationally. A lot of people see that just as their role, something that you do for family, something that you do for neighbours. But local authorities would be remiss if they underestimated in any way, shape or form how important the offer of unpaid carers is to both supporting our communities, but also, frankly, helping us to manage the resources we have available to deliver care and support.
So we take our offer to family carers and unpaid carers really seriously in Dorset, and there's been a huge amount of work done in the last 4 or 5 years to really move that work forward. The legal framework that sets out our responsibilities for carers sits within the Care Act, and carers have statutory responsibilities or statutory rights in their own right. And it doesn't matter if the local authority funds the care for the person they look after. The responsibility remains with the local authority to assess, if requested, the needs of a carer and provide them with support in their caring role if they wish to continue to care. So according to the 2021 census, as I say, 35,505 people identified themselves as a carer. You can see the breakdown of that. And I'm going to talk to you in a little bit more about our Bridget tool shortly, but I want to just draw your attention to the fact that on Bridget, which is an online portal, 21,770 people have registered as carers in that on that portal and have developed over 21,000 self-help plans. And I think that's an important figure if you offset that against the number of formal assessments we've done under the Care Act. What that tells us is that there are a significant number of carers in Dorset who have found solutions to support themselves in their carers roles without requiring to come through to the local authority for a formal Care Act assessment. So if you think about those figures, and I want you to know, aged 5 and above, over 9.7% of the population in Dorset provide unpaid roles, and that's fairly consistent, slightly higher than the average both nationally and in the southwest, but not inconsistent. And 6.8% of unpaid carers in Dorset provide over 50 hours of care. And as I said earlier, over 107 people that we assess are over the age of 85. Now, really importantly, our carer strategy was developed in Dorset a few years ago, and that was co-produced by Dorset carers. I think we've recognised the value of carers' voices in the development of strategies, both with adults and in the birth to settled adulthood arena, where the Dorset Parent Carer group also helped us to design the key outcomes for for children in that birth to settled adulthood care, recognising the impact on their families. So again, some figures in the last 12 months, 702 carers assessments, 77%, as I said earlier, were on their own, 625 reviews. We're currently supporting over 100 young carers in our birth to settled adulthood team, which is a high portion. We've deliberately brought that cohort of young people into the birth to settled adulthood service because we wanted to recognise that they have as much right as anyone else to progress well into adulthood, and we needed to have a service that held them and recognise that transition. Obviously, I'd love to draw your attention to that quote, and I will read it out. I'll indulge it. This is a quote from the chair of the carers group, which is independently chaired. It said, "To effect real change, you need to develop a culture in which the key individuals genuinely invest. Dorset is very privileged to have a group of people in influential and operational positions who have wholeheartedly committed themselves to changing that culture by involving carers at every stage. The offer for carers has significantly improved over recent years, and we're confident that we'll continue on that path." And that community of people who are influential is not talking about the likes of me. It's talking about the likes of people, my colleagues down the table, and Chris Norman, who's our carers lead, and in those partnership working with the NHS, with the community voluntary sector, with providers, and most importantly with carers themselves. And partnership is absolutely key to everything we do to improve outcomes for carers. Next slide, please. Now, as I said, a lot of the initiatives that's been developed on the back of the carers strategy are about enabling carers to support themselves in the communities in which they live. And a number of carers want small solutions. There's a very well-known carers in the Southwest who wrote a self-help guide called "If Only I'd Known This." And her statement was, all I needed for the first 10 years was a bottle of whiskey and 10 good friends. And then she needed something more. So our approach to supporting family carers in Dorset is to give them the tools in the communities in which they live to help themselves, and then have care pathways through if they need a Care Act assessment and additional support. And the Bridget tool does all of that. It has on one platform the information and advice and the community connectors people have, and then it has a facility that allows people to come through for a formal Care Act assessment if they need it. And most of our carers assessments are undertaken by a dedicated cohort of carers caseworkers that sit within the Adult Social Care Operational Service. They provide that support to people whose care is funded privately, as well as funded by the local authority, and they do a huge amount of our monitoring of carers, our evolution of local community groups. They are really important catalysts between community office and the local authority itself. You will see that the carers representative groups are really key, and you'll see on the right-hand side that we have a number of really key providers. The Pan Dorset Carers Group is a co-produced group chaired by a person with lived experience. We've got, they've co-produced a carers journal that helps Dorset carers, and we also have a new carers contract which bids to support the right providers to deliver all age carers service. And the chair of the Pan Dorset Carers Group was part of the tender evaluation process for that. Can I have the next slide, please? I thought you might want to just have a sight of the typical journey of a carer who actually does come through for care and support and a Care Act assessment. So if we do get a referral through for a Care Act assessment, our approach is that there's no wrong front door. Chris and her team oversee all the carers assessments to make sure that the right people are picking up the assessments, and whether or not, as I said before, it needs to be a joint assessment with the cared for person or one undertaken in their own right. And the story we've got in front of you is a real story. It's about a woman who was supporting her 23-year-old son. And what she found is that her need to attend to her son meant some of her own needs and aspirations were lost in that priority. So we supported her through an assessment of her own need, and she was able, through that process and that focus on her, to identify the areas where she was struggling. What she was really struggling with was her weight. She was really concerned about her weight. She was struggling with her household management. She was struggling with her mental health. So through a direct payment, which allowed her to pay for Weight Watchers, really simple solution designed by her with her, helped her to improve her mental health. Considering she was able to access counselling to support her to navigate the world for her, and she was able also to pay for someone to come and help to sort out her house. That's one story. What's really important is the outcomes and the impact co-designed with the person themselves. Next slide, please. So this is a little bit of the commissioned activity outcomes. You'll have seen in the paper, we do a lot of work in partnership. And what I wanted to highlight for you is some of the successes that that partnership work has produced. So the Carers to Support Dorset, which is our dedicated carers service, has at the moment got 8,192 active carers registered working with it. And there were 2,500 196 referrals into that service last year. They actually support 168 young carers, so more carers than we currently have within our service. Again, because those individuals, some of those individuals get all they need from that external community-based service. Help and Care My Time is a new initiative that we are about to launch in November, targeted at those very young carers. And as I say, I think it's quite shocking that some carers, young carers, start their caring role as early as 5. For the forward carers ID cards, it's really important for some carers to be able to identify that they are carers and have a card with them. If they, for example, have an accident in the street, it's important that somebody knows there's someone dependent on them in the community back at home. But also we have managed to negotiate with a number of businesses. We currently have 357 who will offer discounts to carers who can produce a carers ID card that will allow them to get discounts or priority access to resources and services within the Dorset area. And we've currently got 3,796 carers who hold those cards. Swan Advocacy have which is one of the advocacy services, currently provide counselling for provide support for carers, and we've seen a 47% increase in carers using the advocacy service there. And Leonardo Counselling provide dedicated counselling for carers if they choose that route. And there were 98 carers supported last year with specific counselling support. And we are just about, as part of our DIPS programme, which is a contract with the community and voluntary sector, has a number of arms to it, but one of them is particular support around early recognition of people who are admitted to hospital. Is we're just starting a pilot to identify with carers upstream when someone has elective surgery, whether that's the cared for person or the carer, so that carer needs can be identified and planned for. And I think that's all I wanted to highlight in addition to the report you've got.
Andy, thank you.
Councillor Andy Todd, Coal Hill, Minster East. Very superficial question, I apologise. My children, my daughters, strong, independent women. At the age of 5, I wouldn't have trusted them to make me a cup of tea. Can you give me some indication of what we are expecting of a 5-year-old carer and what support we might provide to them in real terms?
Respond to this one. So I think it's not really about what we would expect from a 5-year-old, because clearly we wouldn't want any young children to be in a position where we're expecting them to care for an adult. Often these are things that grow organically within a home. So, it might start by being, can you fetch this for me? Can you do that for me? And it's something that kind of evolves over time. So I think, we would like to see that children are not having to be in caring roles. But, the reality is that obviously there are some who are, and we have to have that support in from 5 years old. I think children's services and the young carers team do a lot to try and mitigate some of that. And we're working really closely with our colleagues in the young carers team, so my team and the young carers team, to really support the way that work is undertaken and how we understand the caring roles and how young people move through that and then into adulthood when they reach that point. And the young carers team will do lots of work around trying to make sure the family have information and advice, and the right information and advice, so that we can relieve that caring role from that young person.
I struggle. The data, it says, from the age of 5, and the moment you start including cohorts within data, there is an expectation or an assumption, isn't there, of contribution. Is there a danger that we institutionally start expecting?
I would really sincerely hope not. The service is targeted because, as Chris says, that's the reality. We have young children who provide support for their family, and what we want to do is gather the information and evidence about that so that we can make sure that we meet their needs. As Chris says, we have absolutely no expectation.
So my question would therefore be, this is an individual who has been identified as having a need for caring in the first place. The fact that the child is providing a degree of support is in addition to whatever service we're already providing. It shouldn't be built upon that expertise. How are you identifying these 5-year-olds first and foremost? And how is it that whatever we're providing isn't sufficient in and of itself?
You want to go for that one?
Yeah, thank you. I would say that actually quite often we don't know who they are. So, you know, they aren't necessarily people who are known to the local authority. And that is a challenge for us, because obviously if we don't know that they're there, then we can't offer them that help and support. Often these children might be more likely to be identified through school. So schools have a really big role, and my time, Young Carers Service in particular, doing a huge amount of work with schools, and they're linked in with huge numbers of the schools in Dorset to try and help them to identify, you know, so you might see that through reduced attendance, you know, children's behaviour, the things that we would expect to see. So actually being able to identify those young people so that we can then offer the right support to the parent is really crucial. And that is something that we are continuing to work on with My Time, who are already established in that area. And as we then become aware of those people, one of the things that I do when I link with Young Carers team is make sure that we get the right information and advice that goes back into that family, offers that help. It might offer, often it is really straightforward things, equipment, technology, you know, really straightforward answers that actually then help relieve the caring burden from the child.
But the gateway is from the child safeguarding doorway rather than adult safeguarding. And is that reflected in
2 gateways, I think. So looking after the needs of children is everyone's responsibility. And if we had an adult worker entering into a household and there was a child in that household, I would expect an adult practitioner to be thinking family, to be looking at, is there a child who's taking on roles and responsibilities which would not be reasonable.
But we were indicating that the only reason we were finding out about these child carers was because of the child referral at the front end. It wasn't because somebody was going into it and identifying there being a child in the accommodation. It was that.
I don't think if that was the impression we gave, that was not what I think was intended. I think it was recognising that a lot of the times referrals for young children where the parent themselves might not see themselves as having a Care Act need, so we might not have had an adult referral, then a lot of our work comes through children's social care or through education. However, I'm absolutely clear that if we do a Care Act assessment and there is a child in the household, I would expect frontline social workers to recognise that and to be talking about young carers referrals. And to be working with children's social care on the vulnerability and protection of that child.
Am I able to just answer that? So one of the things that people do come to me and say, oh, actually, I've identified a young carer, and we do work to join that up. But also there has been young carer awareness training that's been available throughout adult social care and has been delivered through Carer Support Dorset. Who have some specialist knowledge in this, and all of my team have done that training, and other people within the wider workforce as well, so that we do know that when we are going into a situation, if we are seeing a young person and picking up on that we're then making sure we do the right thing.
Sorry, could defer to Jansen. Sorry, I mean, I think the question that you're saying is how many people are going through this process? How many children are referring from the child side? How many are coming through from the adult? This is all about my personal interest protecting the children. It's finding ways that we can anticipate problems and provide them with the support at the front end. I worry that there are children out there who are carers who may be picked up by schools and then may be picked up from the adult safeguarding side as well, but not all of them. And I'm trying to find out, are there ways that we can more integrate this into the child safeguarding side as well? And I'm sure they are, but it's not being.
That's why we
discussed
put the
here.
service within birth to settled adulthood.
Yes.
Exactly, to give that connection and that interface between children's and adult social care. And I would.
John has indicated he wants
Suggested
to
that
come
I
in.
give way to.
Yeah, I mean, I think that the point of the reference of the 5-year-old is just that we're aware that that can be the case, but it's very much the extreme. It's not the norm. And what we're trying to ensure is that we've got that holistic services across all ages. So working with colleagues in children's to make sure that we're supporting all people. So I think that really was the point of that reference. It's not a strategy. It's recognising that that can be the case and responding appropriately. Hope that helps.
I think that's really helpful, and I think what you highlighted actually is a really important point. And we've also got this new service starting next week, so I'm just wondering whether when we get to our forward plan at the end of the meeting, we consider if we want to add maybe a 6-month review, see how the service is bedding in. So perhaps next summer we'll bring a whole themed item around that whole subject to committee. Chris.
You.
And then Bridget.
Chris Kippax, Yetminster Ward. Julie, you mentioned that there's been a 47% increase in the carers accessing advocacy.
Yeah.
If you said the absolute numbers, I'm sorry, I missed them, but it's quite a large percentage increase overall. Can you give some indication of the numbers we're talking about, and any explanation as to why that is quite a significant and sudden increase? Sudden's a bit wrong, but steep incline.
I will have to separately provide you with the numbers. I wrote them down, but I have a notebook full of figures at the moment, Chris.
Sure.
But I think it's because I think the honest answer is it was from quite a low benchmark. And I think the advocacy service has become people have become more aware of the advocacy service. But Chris, are you more familiar with that?
I can add a little bit, yeah, thank you. So you might be aware that we changed our advocacy service from Dorset Advocacy 3 or 4 years ago now to Swan.
Yeah.
And one of the extras that Swan have is a dedicated advocate for carers, which isn't something that we've had before. So that has taken a little while to kind of bed in and to get some traction and for people to be aware of it and for us to promote that and to make the referrals and things. So I think that increase, as Julia says, has been quite low numbers, but actually now that the word is getting out and people are more familiar and it is kind of more integrated, then that's, it's good that we're seeing that it's being used.
And I found my figures. So the baseline was 26 and the increase is 49. So it's a big increase on a slow benchmark. That's baseline.
So that would tie in with the increased publicity that perhaps, rather than anything more, absolute, that
I think
might
so.
reflect on services. Thank you.
Bridget.
Councillor Bridget Bolwell, Bridport Ward. As a former designated safeguarding lead in a very large primary school quite a long time ago now, I would say that there's a huge hidden population of young children who are looking after not only their mother generally, but also their younger siblings. And in school, attendance was a massive issue because the children, this carer, young carer, 8 years old, was frightened to leave their mother at home because of what she might do. And nobody knew about that. Nobody knew about the child who was getting up in the morning. His mother had been gambling all night because she was addicted to gambling, and she was in America somewhere online, gambling all night. So he was getting up, giving his sister breakfast, getting them ready for school, because he wanted to go to school to get away, actually, from the situation at home. And the only reason we found out about that was because he fell off the draining board, the worktop in the kitchen. He fell off it. And so he came to school with bruises. What happened? And he had to climb up onto the work surface to get his cereal bowls out for him and his sister to have their breakfast. Fell off, and anyway, that's what happened. So there's a massive population of children who are in that situation, lots of different situations. So my question is, how much support or training is there for schools, particularly primary schools?
Bridget, I think it's a bit hard because this is the adult team rather than the children's team.
Sorry. It was just that we're talking about young carers.
I really, there is an overlap, but I think you're straying perhaps too much into the children's purview, and I don't think it's fair on these guys to try and answer something that Children's Services would know better. But if I ask Anthony to make sure we keep a record of that, and we'll fire it off to Children's Services after this meeting and get you a response.
Okay, thank you.
Oh, morning.
Councillor Carl Wood, Gillingham Ward. Just a question about the commission services you have here. How long the agreements are, what the duration of the agreements are, how often are they reviewed? Because obviously things like the card, for example, the ID card, people get a life based on it effectively, and then if you revoke it, kind of traction to get something like that going again if you do things like that. So in terms of stability for people using these services, how are you managing that?
I'm definitely going to defer to Chris on when we changed our contract, so our contract for the ID and discounts card with Forward Carers, I know that is 7 years. I'm not in commissioning, so you'll have to forgive me, I haven't got all of the detail, but when we moved from the previous provider to this provider, there was an agreement made that any of the cards that were already in circulation would continue to be honoured, and that when they have a natural expiry date and then they're renewed, and that at the point of renewal, then they would move on to the kind of Forward Carers branded cards that exist now. So we wanted to make sure that there's that continuity, because carers are enormously busy people, and we don't want them having to kind of undertake lots of extra processes and do things when something changes that's originated with us. Does that help?
Yeah, I mean, is that across the board approach? Are there other approaches you take? Like, for example, that's a good example with the cards, but like with the advocacy, I think you mentioned that that's changed over.
So the carers advocacy was a new addition with this contract. So dedicated carers advocacy isn't something that I believe we had previously. It was before my time in this post, so I'm not 100%, but I'm pretty certain that was the case. So that is a new thing and a new addition, so that's obviously a positive. In terms of our other services, we always try to make sure that things are joined up and that there is a smooth transition. So we've got that coming later this week when we move from Carer Support Dorset across to Help and Care as our lead carer service. And I've been involved in some of those discussions and things. There is a lot of collaborative work between the two services to make sure that everything transfers really smoothly, because we don't want any cliff edges for people who are using those services.
What kind of stuff are you doing around that?
So the people who work for Care Support Dorset are working really closely with Help and Care. We're making sure that things like referral pathways match up and that we've got all of those things in place in the way that we do now. We will continue to operate our no wrong front door approach, which has, you know, the ability for people to come into the service from lots of different places. So the conversations, and they have been mainly more led by my commissioning colleague, but there are frequent and regular conversations, and we've brought people from across the system together into one room to make sure that, and as a series of workshops, to make sure that we don't miss anything and that we've included everything in the whole system to make sure that we understand it and that people get the right support and service.
Thank you.
Jonathan, you wanted to come in?
Yes, really quickly. Just to say that our commission approach to these type of services, particularly these type of services which are very much in partnership with our community, is one of longevity. So they are always long contracts. We recognise that there's always the need to kind of do the wiring, as Chris has talked about, to make sure the people using the service and the provision is there, but it's never something we look at a short term, and we do review those on an annual basis as well. So just to give a bit of reassurance there, it's never a short-term commission.
Julia's been waiting.
If I could just say, if it would be helpful, I could ask the commissioners to just do a summary of those contracts and give you those timeframes as a follow-up.
I think I can answer the question about how often the contract. I think contract review meetings are quarterly with each of the providers.
Thank you. There's so much we could say on this. Thank you very much for both of these details. So we'll take us on now to the next item, which is the Future Care Programme review. Who's kicking off on this one?
Sarah's going to lead.
Thank you very much.
Thank you.
Sorry, bear with me, my computer's just thrown me out while I've been. Sorry, I wasn't ready to go and it stopped working, so just bear with me. I do apologise.
If Chair, by way of introduction, for those of you, just a reminder, Future Care is a programme that we started off effectively at the start of this year. It was initiated a little while before that, and basically it links the adult social care and the NHS together, specifically to aid discharges from hospital, but also prevent people going to the hospital in the first place, settle them and help them not go back upon discharge. It's been working quite effectively by the Health and Wellbeing Board since it kicked off around February this year. And I think Sarah looks like she's ready to.
Yeah, I'm ready. Sorry about that. Again, composure. Thank you. So good morning, everybody. My name's Sarah Sewell, and my substantive post is I'm Head of Service for Commissioning for Older People here at Dorset Council. I've been seconded onto the programme as the Dorset Workstream Lead for the Home-Based Intermediate Care Workstream. Ed Barry from Newton is also on the call today, just in case there's any kind of questions on the wider programme. But I've just got a short presentation just to kind of take you through the report. So the purpose of today is to provide you with an update on the Future Care progress so far, to provide assurance on the benefits that we've already achieved, and to provide you with an outline of the corrective actions that we've put in place. It's a requirement of the Future Care Partnership Agreement as well to bring the mid-programme review to partner boards and committees. So just by way of a bit of a recap, the Future Care programme was launched in January 2025 following an extensive diagnostic exercise. The strategic aims of the programme are to improve hospital discharge, reduce long-term care needs and enhance recovery at home. As a programme, we're arranged into 4 delivery work streams, each of which are led by one of the system partner executives from across the Dorset Integrated Care System. Just to give you a very quick overview of each of those 4 work streams. So we have alternatives to admissions, and that's about how we work and the decisions that we make at the acute hospital front door, as the sort of terminology is that we use. And that's about making better utilisation of alternative services that can prevent people from being admitted to hospital. We then have our transfers of care work stream. We often refer to that by the acronym of TOC. So that aims to increase the number of people that we can support through our hospital intermediate care discharge pathways. Then we have our home-based intermediate care work stream, and that's about capacity and throughput into those reablement and rehabilitation services. Our aim through this work stream is to increase the effectiveness of those short-term care support offers at home, and then release that capacity more swiftly to enable more people to be supported through that pathway. And similarly with the bed-based intermediate care work stream, again, that's about capacity and flow through those short-term care beds, but we're really aiming to improve the outcomes for individuals supported in community hospitals and our reablement bedded settings that are commissioned by the local authorities, and really focusing on reducing the length of stay for those individuals that are supported in those settings. Just to take you on to the key achievements that we've achieved so far. So the work that we do in this programme moves very quickly. So at the point of writing this report, this is kind of where we're at with the benefits. So as of early October, we had made substantial operational benefits across the Dorset system. We're projecting a 12.87 million annual operational benefits against our target of just over 12.5 million. In terms of what that means for Dorset Council specifically, £70,000 worth of benefits have already been delivered, and we're on track to meet the £300,000 forecast for this financial year. There is a table within your report at 7.2 which outlines the more detailed savings year on year expected for Dorset Council, just to highlight that to you. Then moving on to the bed-based intermediate care work stream, already we've made a 30% reduction in the number of long-term care home placements that are made after a stay in a bed-based intermediate care setting, and also reduce the amount of time that a person would stay in that bed by 5 days. So really kind of starting to improve those outcomes for those individuals there. Then within our same-day emergency care work stream, around 55 more people are being seen each week through that work stream and through the improvements that have been made there. We are still challenged in some areas of the programme, and we're working really hard to address that. So where we still need to make improvements are around the following areas. So hospital discharge delays, the time it takes for us to support a person to be discharged when they're medically fit, it is longer than it should be. As of at the time of writing the report, the average was just over 9.5 days against a target of 8. We've also have been slightly delayed in our work to embed our new transfers of care hubs. It's taken us longer to embed those approaches, but we've made good progress, and we are really starting to focus in and improve those multi-agency ways of working. Also, an area of challenge has been our capacity within our home-based intermediate care. We've had some reablement staffing shortages which impacted flow, particularly in September, although that position is starting to recover, and I'll show you some evidence of that in just a moment. So in order to address the key challenges, a programme reset has taken place, and as I've kind of alluded to, is already starting to have an impact and improve that position. So the focus of that programme reset, as I say, it is starting to improve that position, and we can already see some improvements taking place. So the focus is for us around really getting a grip on discharge delays, so reducing the number of people that are waiting to be discharged. The delays are already reducing at Dorset County Hospital here in Dorchester, and positive planning and actions in place to support acute trust over in Poole and Bournemouth. We are increasing our focus on system flow and faster decision making. The percentage of people getting home has already started to increase. We've made key appointments to create a new flow team. So that's a critical team for our work, and they will oversee discharges in pathways 1 and 2, the home-based and the bed-based intermediate care pathways, and also oversee those caseloads to make sure that we're really clear about what's happening for those people that have been discharged, understand their plans and ensure that we properly manage the exit from those onto whatever they need next if it is they can't be stepped down to independence. Also, we've had some additional Newton resource that's been invested into the programme at no extra cost. And those actions are looking to reset the position and get performance back on track by the end of December. I just wanted to share with you the impact that's had for Dorset Council in particular, our actions around programme reset. So the screenshot that you can see here is a snapshot that I took from one of our dashboards. So part of the Future Care programme has been about how we improve visibility over our data so we can see what's happening, we can understand our performance with more clarity, and we've got one version of what we're looking at. So what you can see here, so Dorset Council have prioritised support to that programme reset, and we've already made that positive impact on Dorset's acute hospitals. This shows both the position from Dorset County Hospital here in Dorchester and the acute trusts over in Bournemouth and Poole, just to give you that assurance. So what you can see here, the graph on the left hand side shows that we're reducing that length of stay. So we're bringing those delays down. We've brought those delays down by 4 days of late. Current average is around 8 days, and you can see we're starting to increase the number of, or the percentage of people that are getting home with recovery focused support. So we've increased that figure by 5% since the report was written at the beginning of October. Finally, before I just come back round to the recommendations, I just wanted to just bring this to life a little bit in terms of what this means for Dorset residents. So a couple of case studies I thought might be helpful. There's a bit more detail about the gentleman referenced here, Lewis, in section 4.12. But Lewis was a gentleman who was supported home from hospital with home-based intermediate care. One of the improvements that we've made is the deployment of a reablement app, which is used by our reablement providers, reablement support workers. And what this does is gives greater attention to goal-focused reablement. And that approach enabled Lewis a swifter regaining of independence with his personal care and a swifter step down of that care so we could free the resources up for the next person. And then finally, just wanted to tell you about a lady that I've called Penny for the purposes of this case study. She was supported by our Care Dorset reablement service, Castleman Plus, up at Blandford. At the time of discharge, Penny was completely reliant on care and support, and she needed 2 carers and equipment to mobilise. But with recovery and reablement and therapy focused support, Penny regained her independence after a short stay with Castleman Plus, and she was discharged home with a small care package. The likely alternative would have been is that Penny would have probably needed to have been admitted to a long-term placement in a care home. So it just gives you kind of an insight of the real difference that reablement and therapy support can have for individuals. So just in summary, the recommendation for committee today is that you please recognise that the programme is continuing to make progress in those improving outcomes for people and the delivery of the financial benefits for the Dorset ICS. We do recognise we've got more work to do to further reduce the average length of stay for the people that are in hospital that require further support.
Thank you. I see that you do have somebody here from the Future Care programme, but
yes,
he's not the person that I was expecting to see that's been put on my list. So
no, were you expecting Dylan?
Yes, I was.
Yeah, I think Dylan's on leave today. So Ed Barry's joined us from the Newton team in case they're for any further information or requests that we can provide.
Morning, welcome to the committee. Is there anything you'd like to add to the officer presentation, or are you just happy to answer any questions from members?
Morning all. No, yeah, very happy to answer any questions and nothing to add to Sarah's presentation, but lovely to see you all, albeit virtually.
Yeah. And welcome to the committee. Okay, so over to member questions, and the first member I have is Vice Chairman, followed by Chris.
Thank you, Councillor Jane Somper, Beacon Warden, Vice Chairman. So thank you very much to the team for the work that's gone into this whole programme so far, and also for these detailed reports. Thank you, that's really helpful. But you've added some context with your slides, Sarah, which is helpful, which has answered several of my key questions. Obviously, the delays in leaving hospital was really the main focus, one of the main focuses and one of the main reasons for this whole programme. And it was disappointing that that hadn't reached the point that it was supposed to have done within the time frame. So, and I've got a lot of questions, and I know others will have questions, so I don't want to dig down too deep. So I'd like, now you've got a reset that's been pushed through now. So I'd like to understand more about that, what that reset actually entails, what change you have made, and why you feel that the initial programme was not as effective as you had hoped it to be in that particular area. I've got other questions, but can we start with that, because that's quite fundamental to the programme. I don't know who wants to answer that.
John's got his hand up. Yeah.
Jonathan.
Oh, thank you. We're at the midpoint in the programme, which I think is important to stress. So it's generally best practice to do a kind of review of how performance is going, which we've done. We're actually the contract holder at Dorset Council, so that adds another element of the work. So you know, what we saw in the programme early on was some really positive performance. And what we've seen sort of at the point of the mid is that some of that had fallen off. So that's the sort of impetus behind sort of looking and making a reset. What we've done is recognise some of the areas where that's dropped off. We've recognised some of the areas we needed to turn up the focus. The no criteria to reside figures are looking much better since the report was published. So we are constantly in this programme of change and, you know, programme really at this point of stabilisation, I would describe. So the reset's really coming as a result of that. It is incredibly complicated in that it goes across all of those different organisations and across the whole of the county, so the BCP area as well. So I don't think we can ignore the level of complexity, but what we are seeing is positive progress through the programme, but some challenges that you would expect really at the midpoint from my perspective. And I think what we've started to do through this reset is to address a lot of that. So I know that the programme will continue to come back. It's really important that we illustrate progress and also some of the challenges that we're encountering. It is a really challenged time of the year as well. I think that's the other thing I would just pull out. We are in winter. This time of year, we always see greater challenges in terms of discharge. We often, in years gone by, used to receive additional money to help support purchase of the services to support that. We don't see that this year. We didn't see that last year. So I think, you know, it's really important that as a system we've taken this approach, because, you know, at the end of the day, there isn't that additional resource that's just going to keep flowing to put plasters on this. So fundamental fix is what we're trying to achieve through this programme. But I'll invite Ed in if there's anything you wanted to add to that response.
Thanks, John. I think all I'd add, I talk a lot to the, as if hitting the midpoint now, the work done to date has been, particularly in the transfer of care work, has been about putting in place the infrastructure. Sarah talked to that flow team coming on board. Prior to this programme, it was a sort of disparate set of teams all working in a complex space, all who need to work together in a sort of multidisciplinary way to move people through the system and support people as best they can. And that infrastructure simply wasn't there in the guide that it needed to be done. I think it's fair to say it's taken us longer than we anticipated and planned for to get that infrastructure up and running, whether that's getting the digital tools in place, whether it's simply recruiting staff into those roles. And it's delays in those areas that I think has meant that we stayed in that setup phase for longer. In terms of where we are now, and the focus of the programme is really restructuring the programme around using that infrastructure, using those tools, and really driving through to get the impact. And so a key change that I had to sort of point to is the shift of our SROs who are previously against those work stream areas, actually now saying actually the work within the work streams is done now. Much of the work is about making it work in their organisations and inviting them to sort of bring back their coup or their DAS role into the space and enact that change within their organisations rather than being in the sort of transformation space. So that's really the focus of all of us now within the programme, and particularly within that transfer of care space, is all I'd say.
Thank you. That's helpful. And I know that obviously adult services here in Dorset Council be working very hard to improve things. Obviously, you refer to others and other partner organisations, and we know that our largest partner organisation is going through an enormous amount of change. I know there was a blip in August, particularly with this, and I wonder, is there some sort of cultural challenge for our partners, which was referred to when this programme was first presented here, that was going to be fundamental in changing that culture of how things were done and how they needed to be done differently. So I'm wondering if that is one of the areas that has need refinement.
Happily put.
Jonathan.
Thank you. Yeah, we are seeing change across partners at the moment, and significantly in the ICB space. So, you know, we have had to reset in terms of leadership because people have left, retired from organisations. So that, you know, I think that is a constant piece. And when you work in this scale across, you know, a 18-month to 3-year programme, you will continue to see bits change and leadership change within that. But I think that the programme now is structured to reflect that, and you know, there's a lot of leadership going in, certainly from our organisation into that space, to make sure that we achieve this, because really this is our once in a lifetime chance to fix this problem that's been here for decades. So you know, we are putting all of our leadership into that space to ensure that it works. But I don't think you know, changes in one organisation really you know, impact that performance. I think we just saw a number of different conditions come together in that time. And we've moved past it. And we've got, you know, a route through to the next few months. I'll invite Sarah in just to sort of talk about some of the new insight into capacity, and you know, and that is quite a big step forward. So you know, the next few months, this difficult time into Christmas, into New Year, which we see our hospitals very, very full, I think stands us in good stead. So Sarah, I don't know if you want to add to that response.
Yeah, so a lot of the work that we've been doing, sort of to Ed's point around sort of the base work and getting the right framework in place. So we've got greater visibility around the capacity that we have in place now. So if I just refer directly to the home-based intermediate care, the different digital tools that we've put in place now enable the team to work more effectively, so that flow team can see the capacity that's available in a more real-time approach for those providers that are commissioned to deliver that care. So we've got a dashboard that kind of shows a view of those hours, so we can start to work in those different ways around sort of matching where we've got capacity to where we've got people waiting. So we've got that's one example. Plus a lot of the data, the analytics work that Newton colleagues have helped us with has helped us understand where we've got the right capacity. In some cases, we need to do some minor movements to some of that capacity, and we therefore know where to kind of focus our effort now. So that's sort of additional intelligence that's helping us as we start to put those different ways of working in place.
Okay. All right. Maybe we'll come back. Chris.
Chris Kifax, yeah, I think I've got even more than I started with, actually. I was going to ask it. The more I hear about this, the less I think I understand. It just one thing needs question leads to another, but because I was going to ask a question about the reset, a fairly basic question about, you know, what caused you to do, what caused that, what the impact is, if any, further down the line, because you started talking about the money to be saved. I was just trying to relate the two together about, you know, what's been done, what's had to be done to reset, and the implications, I suppose. But there is so much being said in response to Jane's question. I feel as though we're still dealing with sort of the analytics rather than the substance of what's been the initiative to be taken forward, from what I'm hearing. I think that's more of a comment than anything else at this stage, because it just gets so, you know, I need to go back to this and have another look at it, and then perhaps I'll have more focused questions on where we are at the moment. My other question, if I may, which is hopefully straightforward questions, what's the role of the community hospitals in this? You've mentioned the general hospitals, if you like. What's the what about the community hospitals?
Yeah, so from a home, so the community hospital in the context of future care, the community hospitals sit within the bed-based intermediate care work stream. So where those community hospitals have allocated beds that are supporting people on discharge, that's where the community hospitals fit within that pathway. So it's about how we support people to get from an acute hospital into that community hospital, or step up from home to avoid going into the acute hospital in the first place, but getting better use of those assets in the community, and then making sure that if someone's in a community hospital bed, they're only there for as long as they really need to be there. We don't have people there longer than they need to be, and that we're proactively planning their discharge and those multi-agency ways of working to kind of really understand and move people home ultimately as quickly as they can, if they can get home.
So they are part of the...
Yes, very much so. That bed-based intermediate care work stream is all about community hospitals, and then the reablement beds that the local authorities commission.
Thank you.
Bridget.
Councillor Bridget Bolwell, Bridport Ward. Just asking, how many beds are there?
In the...
Anywhere.
In the reablement, I think.
Well, yeah, in the well, from my point of view, in the community hospitals, because we haven't got a Castle, Main, or whatever it's called.
Yeah.
So, say for instance, how many beds will there be released in Bridport Community Hospital as bed-based intermediate care beds?
John's got a hand out. I think Ed will have figures, but I don't have exact bed numbers off the top of my head.
Yeah.
But just bear with me.
I'll let Ed come in with the data, but what I was going to say is you don't in Bridport at the moment, but you will do very soon. That's the site that we're building on the Sydney Gale House. So that will be a reablement centre. So these are this is a piece of work now, but also working with very much our commissioning strategies and our work with Care Dorset over the last few years. We're building that additional provision, and Bridport is going to be the lucky area that gets the first of those centres. But I'll let Ed come in with more of the data, because it's much more than just the Dorset Council area. It's the whole of the ICS, including BCP. So Ed, do you want to come in with that, Ethan?
To answer the specific question, there are 208 community beds across the Dorset patch, community hospital beds, that is, spread across all of Dorset. And I think it links to something Sarah said earlier. So the previous question, that those community beds and the community hospital beds and the local authority funded beds are critical to the flow and outcomes, and providing the best outcomes for individuals utilising the services. And the improvements that Sarah talks to and the ones that are targeted through the programme are then linked to improving the or reducing the amount of time people are waiting unnecessarily for discharge into those settings that are most appropriate for them. So the improvements that Sarah talks to in the earlier presentation, we're using that capacity, sort of investing it back into the system because at the moment, or prior to the programme, people were not able to use the services best for them because of the delays that sort of resulted in the programme being put in place in the first instance.
That doesn't answer my question. So we wait for Sydney Gale to be rebuilt into this reablement centre, which is probably going to be a couple of years. And we talk about keeping people in their communities. So when they're discharged from Safe Dorchester Hospital, do they go to Bridport Community Hospital at the moment?
There's a pathway that if there's a bed available, then yes, they will. Yes.
Right. So my question was, how many beds are there in these different localities?
200.
There's 208 total community beds, and there are 24 of those are in the Bridport area specifically, I believe.
Right, thank you.
I'll add you to the list, Carol. I've got Sally, Andy, and then Carol.
Councillor Sally Holland, Chesilbank Ward. My question is really just, do you have any idea of what your readmission back into hospital after they've been discharged, or is it that they get more interaction from the adult care services to maintain their ability to stay in their own homes or whatever, or do you find that you have got a readmission rate percentage?
Yeah. So there is I can only really speak for pathway. But pathway 1, that's the work stream that I'm closest to. We do have people that are readmitted. I suppose the nature of working in an approach that is discharge to assess. So what we want to do is not make assessments of people's long-term care needs in hospital. So the no criteria to reside approach means that people are discharged home much sooner than they would have done previously. So by nature of that, you will have some people that will be readmitted because of their things that they will be difficult to kind of work through at that point in time, but they've nonetheless have been assessed as being safe to get home. We are seeing that those readmission rates are starting to reduce, and we are kind of working. So part of having the flow lead and the flow team that we kind of alluded to is about those better discharge arrangements of people, and also the providers that are working in the community. They have contact to kind of for advice and support and guidance, and we've got proper escalation plans so that if someone does deteriorate, we have a better chance to wrap around them and stabilise them at home to reduce those admissions. So we will always have some people, I think, that will be readmitted by the nature of people's conditions, but we are seeing those starting to reduce.
Do you think that once sort of the reablement centre in Bridport comes into play, or your use of community hospitals more, is that actually that number will go down because they're in quite a safe space when they are discharged? So they're getting discharged to their own home, which is often more of a risk than if they're in a hospital or care setting.
Yeah, and I think longer term we need to consider the kind of the neighbourhood plans as well. I forget the terminology now. John will remind me what it is. But the neighbourhood team work that's being done, working with Dorset NHS in that space of how we deliver. What do we need in those local areas to have the right offer for people? So actually we get upstream a bit. If our prevention offer is strengthened, then actually we can stop people even being admitted in the first place. So it's all interlinked together.
Thank you. And you wanted to come in on this?
Yeah, I'm Sarah to round it off well. I mean, all of these things are connected. So neighbourhood health work that we're doing for the West footprint will help with prevention of people going into hospital in the first place. The work that Julia talked to earlier on in the committee around people who receive assessments in the community is all part of that. I mean, we actually do look after a lot of people who don't go into hospital, and I think sometimes that circular flow of our population through this is lost. Sometimes we just think about one way out of hospital, a straight line, and of course it's not. So all of these things do come together, but I think in what you see in this particular programme is those 4 work streams working together to make sure that we do get the right people in the right place receiving the right care, and generally that is back to their homes. And what we're seeing already is an increase in the amount of people that are going home. The case studies Sarah highlighted is not unique in this work. That's what we really want to achieve through this, and make sure that if people are staying in bedded settings, it's for the shortest period of time. So that's at the heart of this work.
Can I ask you a slightly impossible hypothetical? You say there's 208 community beds currently available. My economist training comes out, all things being equal in terms of demographic profiles and everything else, what's the optimal number of beds you're aiming to get to in order to serve the existing population? And what impact would that then have, assuming you have exactly what you need, on people re-entering afterwards and requirements for beds going forward after that? What does good look like?
Yeah. So if I could come in, so we're at the mid part of the program, which we've done a lot of the heavy lifting, understanding what infrastructure, making sure our data tells us what we need in the long term. So we're at that stage where we're just able to fill in the colour of some of those unknowns that we've had for many years. So good example of that is our P1 capacity. And Sarah might talk about that in a bit more detail. All of it is not complete at the moment, so we're at that midpoint. We're working towards that, future commissioning plan. But I think we're getting close to that. We probably will be able to illustrate that in full detail at the next time we come to the committee. But at this stage, this early stage, we're not quite there. Some bits we are. I don't know if Sarah you want to talk about the P1 bit, which is more advanced in that requirement, but some of the other bits we're not quite there with, but we will be very soon.
I can expand. So in terms of home-based intermediate care, as I kind of alluded to, kind of having greater clarity of the data analysis. So from the work that we've done, we have, and this is around contact hours of time, we have just over about 2,000 hours per week of contact time for people in the Dorset Council footprint. The analysis that we have shows that we've got more around about the right amount of capacity at the moment when we kind of have the system terminology is surge, but when there's like additional capacity in a particular area, it does get a little bit tricky. So we could probably do with a little bit more capacity in some areas. We need to think carefully about how we commission that, so we only turn the capacity on when we really need it. But that's kind of an example of actually the work that's been done, and by really kind of understanding where our levers are. So if we can get length of stay to an optimal level, that allows that capacity to go further. But it's really about making sure that the support that an individual has is really truly recovery focused, goal focused. So we give people that support to maintain their independence so they can continue that on their own. So that's just an example of that. So just over 2,000 hours of care a week is around about what we need in Dorset from the demand work that we've done.
That's within community. Does that include the beds?
No, that's home. That's home. Yes.
But you don't have the bed base.
So we've got a number of beds at the moment. It's about how we're working around those beds, and that was kind of to John's point. We need to kind of continue to do the work through the programme to be able to kind of test and challenge some of that work, and make sure that we've got the right infrastructure around us, and how we're working around those beds to really make that to get the right throughput through those beds.
Do you want to add anything, Jonathan?
Yeah, I mean, it is quite complicated, so I can see why we're struggling here to illustrate it. But if you think about our goal is to get people home. People are in beds at the moment. Until you build the capacity to get them home, you can't release those beds. So we're in that phase where we've been very much focused in on making sure that those routes out of a bedded setting are correct. As you start to do that, you then can calculate what you need in a bedded setting moving forward. So we're in that kind of process at the moment. The other bit is most of the cost across the whole system is in the bedded space. So once you release that, you're able then to make that reinvestment in the community. So we're in that fix at the moment, but we're not quite there at this stage.
My question is the cost of a bed with the NHS is £355 a day. I just wondered how that compared to a bed in a community hospital and a bed in our reablement centre. And would I be right in thinking that perhaps a bed in a reablement centre is more targeted to that patient rather than a community hospital? But I was just looking at the price differential between the three layers, basically.
Do you have that?
Yes, I can. So the cost of a community hospital bed is on average £220 per bed day. I think for the reablement bed, I don't know. I'd have to double check. I think it varies because we have a number of different beds provided by different services. So it does vary based on the specific site you'd be looking at.
I was just wondering whether if the care is more targeted in a reablement centre, does that mean we get the patient home quicker rather than being in a community bed hospital?
I think if I could go on. I think it depends on the individual and what the individual is considered to need at the point of discharge. So if it's really intensive rehabilitation therapy, for example, the best place for that person is going to be in a community hospital. Because of it's a rehabilitation therapy, health-led intervention that person needs. If it's more about their kind of longer term daily living kind of independence, then a reablement bed with therapy focused reablement goals is more appropriate for that person. So it's about making sure that we've got the right span of beds and the right wraparound support for those individuals, so that we can give the individual what they need, or there's an offer for those individuals in the right place at the right time. I think there is, for some people, a community hospital won't be what they need. It's the reablement bed and vice versa. So it's really understanding individuals' needs at point of discharge, and that's the work that transfer of care hub and working together in that way is doing to improve that space.
Ed, you wanted to come in as well?
I was echo exactly what Sarah just said, and her final sentence was just covered off my point, which is just sort of about, I think, what we want to avoid is being in a space where our bed is regarded as a bed regardless of where it is and regardless of who's going into it, but actually getting to, which is a place which you get to when the pressure within the system gets too high, and perhaps is where we've been in the past. I think where we're able to go into now is actually being able to use the beds and the specialist care and support and the staff and the skills of the staff around those beds for the right person in the right place at the right time. And so being able to, and that flow team having oversight where previously you might have had it one person per site or per bed or per organisation. There was no one sort of oversight across all of the beds and the flow going into them. Now we have that with that flow team going into place and into post, which increases the sort of our ability to make sure and increase the chance of getting the right person in the right place at the right time.
So I'm just wondering, I mean, we are in the process, aren't we? I think we had 3 more reablement centres to build. If I remember right, there's Bridport, Wareham, and I can't quite, I know we've got one in Blandford. I'm wondering what made us decide to build reablement centres rather than try and expand community hospitals? Just, I don't know. I mean, how did we know that the reablement was more important than expanding community hospitals? Sorry if that's a bit, yeah.
Probably need a whole different session to sort of go through the kind of the rationale for that. But I suppose what I would say is, you know, the reablement has traditionally been in the gift of the local authority, so it's sort of an entrance point into our world. So our reablement centres, not entirely the case, but largely the point that we can see higher acuity coming in the years to come. You know, we touched a lot on our aging demographic, but if you think about, you know, in 10 years' time, the needs of someone coming out of hospital to get home probably requires a much more intensive bedded period. And that's what the reablement centres are built to address. So it's not the need necessarily today, but it's the need in the future. But I mean, there's a whole book on this that I'm more than happy to bring back. We are now getting a lot closer, of course, to certainly Bridport being built, and we've got some options to use existing buildings, upgrade those to build in the other areas. So perhaps that's another one for another day, if I could suggest, but hopefully that gives you a bit of a flavour of the decision making.
I think we need some of the NHS money, don't you, Chair?
Could possibly comment.
Thank you. Thank you very much. 2 questions. I'll keep them brief. Thank you very much for the detail in here. I just want to understand the move out of a hospital into a community bed. So that's part of your success and ticking of we've discharged. Do you then add your community beds onto that discharge? I mean, they've discharged from hospital, but they've gone into a community bed, so they haven't yet gone home. How is that classified? Is it separate? Is it?
Do you mean in terms of the calculation or how the person is supported?
What I need to understand is, are you shifting the problem from the hospital to a community hospital? And so, yes, they're coming out of a DCH or Bournemouth, but they're going into a community hospital. They're not yet going home.
No, but so the decision around a person going to a community hospital is because they are deemed to be medically fit to be leaving that acute, but through the work of the TOC, the decision is that person's not quite ready to go home, so they need to be stepped down into the community hospital bed. So it's a route for them to ideally get to a point of being at home, but quite at the moment, home isn't an option for that person. So, but through the Future Care programme, each of those stays in a bedded setting has the oversight through an MDT approach, making sure we're clear on the actions of the person each day, so that we help that person recover and get out of the community hospital bed or the bereavement bed as quickly as they can.
But it's marked as they've left hospital.
Yes.
Right.
Yeah.
Okay. And what's the average kind of time people are spending in those community hospitals? Is there a cut-off point? Is it a 6-week cut-off point?
So we would aim for a maximum stay of 6 weeks. That's good practice in an intermediate care setting. I think Ed will have the live length that will be clear about length of stay for that area at the moment is reducing.
Yeah, I think so. The currently in a community hospital setting, people spend on average 31 days, and that's down from 39 days at the start of the programme, which was the average stay throughout 2024. So it has come down substantially already. But we're targeting to go further. Really, we'd like to get down to below 28 days, which would be in line with best practice nationally.
Right, so that's great across that data. That's really vital. Final question. When this first came to here or overview or wherever it came to, there was a concern around residents in the north of the county who often go to Yeovil or Salisbury who weren't covered within this. Now, I understand they are receiving, they are sort of part of it, but obviously those transfer hubs are not obviously within those hospitals. Can you explain to us, how that's working, or if that is indeed the case for our residents in the north of the county?
So whilst the transfers of care hub we're not changing how we're working within those acute hospitals at Yeovil, Salisbury, for example. Those individuals who are Dorset residents are covered by our Dorset TOC approach. So they will be picked up, so to speak, by those arrangements and any improvements that we're making. So someone from Yeovil will come into a P2 bed within the Dorset footprint, for example, if that's what they need, or they'd be supported home. So the improvements that we make to the work streams in Dorset, if you're a Dorset resident, you will benefit from that, and you will have the same access to those services than somebody that's in UHD or DCH. The approach will span out to those individuals.
Good, thank you. Thank you.
I've just got a couple of points. In the report, there is a section on finance, where in paragraph 7.1 you talk about making £5.8 million of savings in 25-26 against a target plan of 6.6 million. And you say that 4.2 million of that saving is classified as at risk due to operational pressures. Do you want to give us a little bit more meat around that so we can understand it better, and have an idea of what you're doing to ensure that you are able to deliver on those savings? Jonathan.
I'll let Ed come in on the back of this, but essentially we are not the full year through. So, until we complete the year, we wouldn't count the savings. So, at the midpoint, at the point we write this, we're halfway through the first year, and indeed we're halfway through the first year, which started a bit later than we would have hoped. So there's a bit of slip at the start around contracting, which makes it not the full year. So some of the savings profiles change, but generally we don't count it until we've achieved it, and that's within the first full year.
Just to add, if I can come in and just add some specific, so the specifics, sort of the largest portions of at-risk savings actually sit with both UHD and DCH, and what that is reflective of, although I think really positively, both of those providers and the wider system has sort of taken a really ambitious approach to get as much of the cashable benefit from this program as they can, such they can then reinvest and work that through. The plans as they stand, within particularly for both DCH and UHD, it would be what's the word? I think it's right that we, working with those providers, that they are looking at this, the winter, are looking at actually if they continue to see the volumes of pressure and demand that they're seeing. So for instance, in DCH, they've actually seen a 12% demand pressure compared to this time last year. And you see the similar trend across Dorset. So in spite of that headwind, they are maintaining and targeting the savings that are mentioned within the paper. But there is a real risk of that pressure, meaning that we have to put an escalation bed in place. So although there may be or we may have closed, let's say 10 beds or in a ward within an acute one of the hospitals, if they then have to put on 10 escalation beds, that has a chance of mitigating some of those savings. And that's where the at-risk really comes into play, or what it's referring to, saying that although the plans are still there and everybody in the system are committed to delivering on those, I think it's right that we say actually we need to make sure we shore up that risk and prevent any further escalation beds being open that would cannibalise the savings planned. And against each of those, I should say, I suppose that links back to perhaps the reset and really getting on with shoring up the sort of getting the KPIs back to where they are expected to be against the targets we set ourselves, because that will be the fastest route to shoring up the assurance of benefit.
I suppose for us as a committee, we need to have the confidence that this whole programme is about embedding real change that will deliver, and it's not just a sticky plaster that will just get us through a little bit. It's something that's going to make real change and actually change practice, change cultures for the benefit of the people. And so I think as we move forward with the programme, because obviously, as you say, you're only part way through, we need to see real evidence of that. And it is about really changing the way we work, and it's embedded, and it is something that isn't just another passing phase, that it's something that really works and delivers. I think there's no more questions from any of the committee. Jane.
Thank you very much. Just to finish off, so this is to Ed, if I may. You've carried out these programmes in other areas successfully, and presumably they will have had their own challenges along the way. Are the challenges here in Dorset similar? Are they unique to our rurality in any way? Can you comment on that?
Certainly, and perhaps to quote John, I think they could write a whole book on that one, that question specifically as well. But I think and there are some challenges that are similar. I think particularly the organisational ones. I think working in the space, urgent emergency care, and the integrated nature of it, and the requirement for collaboration between councils, ICBs, providers, community health trusts, and so on, VCSE, it requires all of those parties to work in collaboration. And as a result, despite mechanisms existing to try to deal with those tensions, there is still that organizational tension and behavioral tension that that comes from working in a complex system and bringing partners together and around a shared goal. I think Dorset, and I was going to say it earlier, I think when someone asked the question about culture, what's been really heartening, I think, to see is both through the reset and some of the conversations we had in recent weeks. So last week on Wednesday, all of the SROs came around the table, and I think from my perspective, I don't think there's any signs of anybody sort of drifting away or trying to sort of distance themselves from the programme. Actually, a real leaning into from all partners, whether that's health or local authorities, really leaning in and saying, no, this is the programme that we are committing behind to get us to where we want to, rather than what I feared, I suppose, is that sort of, oh no, I'm going to put this at arm's length and try to backtrack from it. Or both local authorities and the providers as well, really making those statements of no, we're not U-turning on this. So that's a consistent problem. I would say there are some things about Dorset that are particularly challenging. I think Sarah's been working in the home-based intermediate care space. I think Dorset's Pathway 1 and home-based intermediate care provision is particularly complex. In my experience, it's the most complex I've seen. But that is not, I think, has not deterred, I suppose, the ambition for change and working that through, and actually getting to a place of actually, as Sarah was quoting sometimes, we have a good handle of, what do we have, where do we want to take it, and what are the opportunities to go further. And so, yes, it's probably more complex than some of the other systems I've worked in, but the sort of the opportunity is nonetheless, if not greater. And I think there are probably a whole host of other questions, other answers and details in there I could talk to as the but I won't.
Thank you very much, Ed. Does that satisfy you all? Yeah. Okay, so we have a recommendation on this paper to note the progress of the programme that it continues to make in respect of the improved outcomes for people and delivery of the financial benefits to this care system. I think we've done that, but also recognise that more work is required to reduce the average stay for people in hospital ready to leave with further support. I'm sorry, what I had written down here is a complete jumble of words. It's not as clear as it should be. But I think through the discussions, we've obviously picked up that it's a very complex programme. We've got not just complexity with geography, with need, but also with cultures. And I think as we move forward within the budget constraints, throw that in as well, we need to see that things have moved on by the time you come back to us for the next time. But it's a good start. Let's keep up the pressure and let's get this done.
Good luck over winter.
And let's hope for a very mild winter. Thank you. And thank you very much for stepping in, Ed. Okay, so it's 12:30. We still have 3 substantive papers to go. Do people want a 10-minute break? Or do you want to keep going? 10-minute break.
Typical ladies. Yeah. Oh.
It was, yeah. Well, it was
Right, moving on to our next item, which is agenda item 10, the cost of living challenge update. Laura Cornett is going to take us through this, but we also have the portfolio holder, Councillor Ryan Hope, online. Hi, Ryan.
Good afternoon.
Is there anything you want to say initially before Laura presents the paper in detail?
Yes, thank you very much, Chair. Obviously, once again, thank you very much to you and your committee for tabling this item on your agenda and monitoring the progress of this year's project. The papers before you and your agendas obviously identify the mid-year progress for this year's cost of living projects. And what we're asking you to do is to review the progress and obviously note that we had communication from government that the funding stream, which is the Household Support Fund, will no longer continue and is going to be replaced by a Crisis and Resilience Fund. Obviously, Laura's got some more details on that, very limited at the moment, but we'll obviously update Council as and when we receive that. So we're asking the committee to review the progress and make comments against the progress of this year's projects and activities. Thank you.
Okay, thank you, Ryan.
Thank you very much. Thank you. I'll just do a couple of highlights from the paper quickly. So as part of the background, for this financial year, 25-26, a joint budget of £1.2 million was allocated, 700,000 from the Household Support Fund and 500,000 from our cost of living programme. So to make the money work more efficiently, we've managed that money together. So as the midpoint in the year, so all the figures given here are to the end of August. So project number 1, homelessness support. So this was given a joint budget amount of 367,000. And that very much covers rent arrears in advance and deposit payments, tenancy sustainment, a media information awareness, also some emergency food vouchers, emergency top-up. So key statistics here is up until the end of August, 44 households were supported in total, and the breakdown here of those 44, 14 were households with children, 26 were households who declared as having a disability, and 4 of those were aged over 65. Project number 2, which is the Healthy Homes Dorset scheme. So the key statistics here is that a total of 53 households were supported. 11 of those had children, 29 of those were households with a disability, and 4 of those were aged over 65, and other low-income households were 20. Project number 3, Citizens Advice Cost of Living. The key statistics here is that our cost of living caseworkers have helped a total of 1,258 clients deal with a total of 3,408 issues. And that's achieved income gains to those residents of 851,333. Project number 4, which is the discretionary housing payment allowance. So as in previous years, the criteria for this fund from central government is that the department have to spend the central government grant allocation before we are able to allocate any cost of living funds. So £48,000 from cost of living was allocated to this. So currently they are standing at £63,440 remaining, and that was with 5 months left to go. So unlike previous years, they don't normally touch our cost of living money until Q4. However, there has been a significant increase in demand on this for commitments. So they do, and the department anticipates starting to draw down on the cost of living funding during Q3. Project 5, which is the Disabilities Facilities Grant, which was given, currently has £17,031 spent. So far, they've given 3 grants out, 2 for replacement boilers and 1 for replacement windows, which has totaled 17,000. Project 6 is the Community Transport Network. So they have funding panel met in September and they've supported 22 community transport applications to the value of £45,000. And they will continue to accept applications hopefully until December, when they anticipate spending the full 60,000 allocated. Project 7 was the Emergency and Affordable Food Security. This is a targeted programme to our food banks and our social supermarkets. This is given 2 rounds of funding. The first was open in July, and we're currently open at the moment for the second for the winter pressures. So to date, these projects supported a total of 4,811 households up until July. So Project 8 is the Sustainable and Affordable Food Security projects. So these are individual projects where we are able to give funding to support food projects that take a preventative and upstream approach to tackling food security and building community resilience. So these projects so far this year, which have been authorised by Councillor Hope, are Cooking for Good on Portland, Get Dorset Cooking, which is a 6-month pilot, in supporting community groups to run their own community sessions, building on previous training and addressing localised barriers. Ongoing support to the Volunteer Centre Dorset for basic food hygiene certificates. And the next one would be Not Just Sundays, Early Evening Supper Club based in Wareham, which addresses food insecurity in Wareham for a weekly community supper and of using surplus food, and a cookery club that teaches basic cooking. Community cooking sessions in Westham, which covers budgeting, tackling food shopping, eating healthily, energy efficient cooking. The Bridport Community Cook-Up, which is a Ripple workshop, and this is a pilot bringing together a diverse Bridport residents through shared cooking and meals. And then also this funding supports the Food Network Development and Meetings, which is coordinated by Emily Brown, and this encourages food projects to work together with the aim of reducing food bank referrals, stronger evidence-based partnership working, identification of gaps and provision of future funding, increased understanding of visibility across their local areas. Project 9, support for older residents on benefit applications. So very much these projects are aimed at improving financial resilience amongst our older residents across Dorset by increasing access to welfare benefits and related support. Having learnt from some of the statistics we received, which I presented back in June, we very much have pushed towards more innovative approaches, such as working alongside our PCNs to use targeted text messaging to residents that we feel that may be eligible, and then because they may be able to get home visits to help those who are unable to complete them themselves. And then where some of the projects are deemed more complex, beyond simple form filling, they are also supported by citizens' advice for that. And Project 10 is the Children's Holiday and Food Programme. This supports an additional 1,000 places as part of that summer programme, because demand has significantly increased for the programme over the last couple of years. So overall, the cost of living programme is on track to deliver projects within the agreed costs and timeframe. And then full monitoring and statistical impacts funding will be provided to the People Health Scrutiny soon after April 26. Now, one of the main focuses of this paper and the recommendations is information regarding the new Crisis and Resilience Fund. At the time of writing the paper, we only had a few bits of information available, and I did talk to the chair about giving you a verbal update on this now. Okay, so at the end of October, myself and a couple of other Dorset Council officers attended a local authority update by national government regarding the new Crisis and Resilience Fund, which I'll refer to as CRF. The National Government Policy Office explained their processes on how they've developed the new fund, including feedback they've gathered from local authorities and third-party organisations on the strengths and weaknesses of the priority areas of the Household Support Fund to help frame the new fund. So this includes evidence they've collated on crisis support, food support, housing support, improving financial resilience within the community, and scheme management. So the new CRF fund has that's been created has three main outcomes: provision of effective crisis support, improving local communities' financial resilience, and bolstering community level support. There'll be £1 billion nationally available for this fund, and the scheme will run from the 1st of April 26 to 31st of March 2029, which is a 3-year programme. The Household Support Fund was always issued annually. And what they will do is consolidate the Household Support Fund and the Discretionary Housing Payments Funds. The structure of the fund will have 4 main areas. One will be the crisis payments, providing support to those experiencing crisis within our communities. A housing element, so the discretionary housing payments to provide a financial support with help with rent and housing costs. Resilience services, funding for services or programmes delivered by local authorities or external providers to improve financial resilience. And the 4th, community funding, investment in activities to improve local welfare landscape. Full details on those 4 were not fully available within the webinar, apart from reassurance regarding the discretionary housing payments, because for years 1 and 2, the current local authority allocation will be maintained and it will be listed separately on our grant termination letters. And then in year 3, the local authorities will receive all of the crisis resilient funding, including the housing element, as one figure for us to set the level. The timeline they've laid out for bringing this in. So in December 25, provisional allocation will be publicised to all local authorities. January 26, the CRF 3-year guidance finalised will be publicised. January and February 26, there'll be another local authority webinar so we can discuss more of the detail. Also in February 26, we'll be issued with our final allocation and grant termination letter. And then on the 1st of April, the programme will launch and there'll be ongoing local authority engagement. Thank you very much.
It's quite an update. You make sure that we get the detail of that.
I've already submitted to Anthony to share with the minutes.
Before we move on, it is 12:51. I do have to have committee's permission to extend the meeting beyond 1 p.m. With agreement? Yeah. Good stuff. Good strong stuff, my committee. Thank you. So, okay, you want us to kick off?
Thank you very much for the update. Other people I'm sure are going to ask about the report. Just one question. Did in the webinar, did they outline a form of any form of reporting back to them? Did they express?
They didn't give us the detail, but yeah, so they didn't give us the full detail on what will be expected. However, they did include that under scheme management of things they have reviewed. That will come out, I think, in our information update in December or January.
So you can't obviously anticipate what that's going to look like in terms of review, setting up and being informed and all the rest of it.
No, but with the Household Support Fund and the discretionary housing payment, we feel it would be quite similar. They are now quite similar in how we report back. So we would anticipate it would be something along the same lines.
Okay.
Bridget. Councillor Bridget Barwell, Bridport Ward. I noticed in 3.4 in the paper under new Crisis and Resilience Fund, it says that the new fund will have a preventative focus, which is great, so that households don't reach crisis point. And it says working with voluntary and community sector. So does that include, I guess, CAB? I wonder what other community sectors will be involved in that.
Absolutely. So yes, their ambition is to move away from more crisis approach to a much more preventative approach. And so they're out of the 4 pillars they talked about, and apologies, it's come verbally to you, under resilience services. So funding for services or programmes delivered by local authorities or external providers. So external providers include Citizens Advice, to improve financial resilience. So that's much more working in that prevention space. And that definitely was the theme coming out, is that the new government fund, yeah, it's not just about crisis, it's supporting people to support themselves, within that community.
Does that include Home Start as well?
Possibly.
Yeah. Andy, and Chris.
Andy Todd, Cole Hill, Wimborne Minster East again. Item 6. I don't know whether you can go into the details. Community transport network. I'm an avid fan of deprivation. Is not just about money, it's about access. And I'm what they call a double hatter. So I also sit on Cole Hill Parish Council, and I know that we at Wimborne and Pampill all contribute to Dorset community transport. We pay for a little bus that runs around and nobody really understands who's allowed to get on it. So we've got a communication issue to go on. But I'm interested to know, what do those parishes that don't have the luxury of having precept that we have available to them to spend, how easy is it for people in more rural areas to be able to access these funds, and how many of them do? What areas within Dorset don't currently take advantage of these?
I'm not an expert in how the wider community transport looks, but there is a fund, a much smaller fund that sits within our community transport team. So there is equal opportunity to apply for funding across the whole of the Dorset Council area. Some of them do receive support, some of them don't. It's quite a complex picture. I understand. I can send after this meeting a list of those that have applied in. But we do have Dorchester Passenger Transport, DCT, Dorset Community Transport, who do have a lot of our community contracts, and they will quite often fill in some of the gaps where there isn't a commercial operator there. So I understand our community transport team have done a lot of work with them. It is an ongoing challenge that I know our cabinet are currently looking into how we can deliver that in the future.
I think on that one, it's certainly worth a deeper dive. However, I would say that comes under the remit of place and resources scrutiny. So you might need to have a word with someone over there, and perhaps
dark side.
The dark side. But yeah, so for now, thank you. But I think as a point of interest, because we are all local members, it would be very interesting to see that list of schemes across Dorset. Absolutely. Because I know where I live, I have the luxury of a commercial bus service once an hour during the day.
Do you? Oh my God!
I'm a town of 15,000 people.
That's urban.
You can't get to Wimborne by bus from Burwood, but anyway,
Can't get to Wimborne from
that's another story for another place.
That's true.
But it would be very interesting to understand, the hinterland around where I am and their access, and I think for some of the more rural wards as well.
Absolutely. Yeah.
So
I will I'll speak to the community transport team and see if they can send out a full brief of what's covered.
An idea of the areas, it may be a map that shows, coloured, that just shows which areas are covered by what would be very useful. Thank you. Okay, moving on. Chris.
Yeah, Chris Kiphouse, Minster Ward. I'm just trying to imagine what a bus looks like. Oh, thank you. Yeah, good. Well, keep plugging away. Keep plugging out.
Yeah, the wheels fell off.
Yeah.
Keep
A
going.
long time ago. Right. So just coming back to your looking ahead at future messages from government, how will the emphasis that you referred to on prevention impact on spend? Do you know? I mean, it's a question in principle rather than in practice. And will there be a specified sum, proportion? How does it work? How do you think it will work?
Yes, so we
And
will.
where would you envisage it being?
Sorry.
No, that's fine.
So like the Household Support Fund, we will be given I think it's end of December, January, a figure, like we are with the Household Support Fund, that's our allocation per year for the 3 years. One of the things that I think we are slightly ahead of sitting in the webinar compared to some other local authorities is where we have this cost of living money that's been working alongside the household support fund. A lot of that, if we look through the detail, is actually more preventative work. We've been trying to move away from crisis into prevention. So some local authorities are very much just dealing with that crisis work still. So if we look at our, like, for example, project number 1, homelessness support, things like discretionary housing payments, obviously community transport. Project 8 in particular, so sustainable and affordable food projects. So we were very lucky in the fact that we, have committed to this funding to try and encourage communities to support themselves, and to whether it be cooking for good on Portland, for example, delivering cookery and education workshops. So we've been working on this program for 4 years now. So we really we're trying to work with those community groups to move people along away from crisis and I need food now to affordable and sustainable. So that's where the social supermarket model comes in, the cookery schemes, upskilling people, upskilling communities, providing them with cooking boxes that enable the volunteers within those villages and towns to support their families and their residents to be able to cook, but budget and affordability. I'm using food as an example, it's the easy one. But we are on that journey already. So I would say, as a review of, once we have the exact criteria that comes in the new year, I would request that potentially, because it was a whole new scheme, we would also potentially go to overview with proposals on how this would be spent. But I think it's really taking the prevention side of the cost of living and progressing that agenda much further along.
Thank you. Yeah, look forward to hearing about that in due course.
Picking up on that sustainable and affordable food security, they are individually really good projects, but I suppose my wider concern is they're targeting quite small communities, and Dorset is a large county. I can think of areas of Ferndown, Three-Legged Cross, areas of our greatest deprivation that run alongside some of these areas. Absolutely. That aren't being touched yet. So it's about, as you move this forward, the importance of looking at removing postcode lottery.
Yeah, okay, thank you. Yeah,
I think that's fair for all our residents.
Yeah, absolutely, yes. And I think with the food one in particular, Emily, my team, has been working with those local food networks and listening to them and seeing what they want to do, because obviously we're not going to tell them what to do. They have to want to do it. And so the projects that we funded last year and so far this year, that's been brought up from the community. We will identify, we always try to identify where there are gaps. So if communities aren't coming in, so then we'll do some more targeted work in those geographies to support that. So thank you.
Vice Chairman.
Thank you, Jane Somper, Beacon Ward. What you just referred to around prevention, which is clear in the papers, it really highlights, I think, the thread that runs through many of our directorates, which is about prevention, which is about strengths-based, and that focus is very much how the resilient part will actually move things forward, and it's really important. And then adults, they obviously prevention, and children prevention, homelessness prevention, these are fundamental. That's just a statement because you said it. So there are some areas here and projects here which look like they're pretty close to their limit on their spend, and there are some which are not close to. I'm just wondering, I don't know how the mechanism works, if you're able to shift any of your funding from one to another, if you're seeing a reduction in spend or less spend or no spend, and yet there's a need identified in another. And how are you able to do that?
Yes, obviously with Councillor Hope's sign off, we are, and we have done previously as well. Right. I would say, obviously, the figures here are from August.
Sure.
Yeah. And when we build this report and speak to all the project managers on this, I would say for the first year, I would anticipate that every single project will meet their budget, and potentially earlier than they have done previously, because there is that continued need. I think I mentioned earlier, didn't I, about the discretionary housing payments. So usually we are talking to them in February about starting to pull down on their funding, whereas now they're saying already before December they will be committing that.
Yeah, I asked that for that specific point. Obviously, there's no reporting in here on sort of specifics on outcomes, and that will come.
Yeah, that will come
presumably,
at the larger report that
said
comes
in
in
April.
the financial year.
And last point is on around promotion of support, which is, you know, important for residents who may need it but might not know about it. So what communication methods do you use to reach those people?
Yeah, certainly. So every year we run our communications campaign with our partners, such as Shelter Citizens Advice, and other partners as well, to really tell people what is available, and they have been very, very effective, particularly around, for example, project number 1, the homelessness support, because what we've been trying to work on with our residents is actually to come to us before you're at that crisis point where you are actually going to be made homeless, so we can actually then put in a prevention rather than having to rehome. So if you have a family that needs a 3-bedroom house, it's actually much easier and more cost effective for our housing teams to be able to work with the landlords to keep them in their home before they actually get to eviction point. Whereas, because then it becomes very expensive and very challenging for us to be able to rehouse them. And that has really, really worked. And so on some of these projects now, we are seeing that prevention rather than crisis, you know, with our residents. So the communications are incredibly effective, which is why we have always kept in that additional funding. So number 3, the media information and awareness, because we feel that's really, really important, because residents will need to reinforce that message every single year with them. But we work really, really closely with all of our partners on that to deliver that campaign.
Can I just pick up on the demand? Because you said that you anticipate that by the end of financial year, that demand will have used up the amount of budget that you've been given for this scheme. Is it that the demand is starting to outstrip the budget? Is demand increasing? So do we need to look at, in the next financial year, increasing the budget to meet the demand?
I'd say some demand is increasing, but because at the moment we're trying to balance that kind of, you know, that crisis and then prevention space. I think it'll be really interesting to see what comes out in December, January with the new Crisis Resilience Fund, because I think that will have a much more of a preventative focus, and I think it'll be a bit more descriptive on what we can and can't fund through that. But so we don't have those details at the moment. But I do feel, because we actually had the commitment of the 500,000 for the duration of this administration, so we'll still have the cost of living money, and so I feel that we will be able to work those together in that more prevention space. But until we have the details of the fund, I don't think we going to know who the winners and the losers of that will be.
Maybe I'll park that one till we have some more information.
Absolutely, thank you.
Next on my list.
Well, Carol Jones, Sturminster Newton. I have to say, Laura, you do a brilliant job. So, you know, and it's not an easy one. I suppose I perhaps should have declared an interest. I'm not sure, only that I'm I'll do it now. I'm a trustee of a recipient of a cost of living with the Family Hub. I just wondered, with some of the rent deposits, and do we ever loan them? Do we get that back at all, or is it just a grant that's gone forever? Or if we're giving somebody sort of some help with, you know, a rent deposit or rent arrears, do they have to pay that back?
I would have to speak to the service about that.
You know what? I mean, that could bring some money back. I think we should look at that.
I would have to ask the service and then come back to you. Unfortunately, our the Katie for revenue benefits is on leave this week, so she wasn't able to attend today, but she would know the answer to that question. but I will find out and get back to you.
Okay. And one of the areas of citizens' advice, do they get funding from anywhere else? Because they are so, I mean, I can look at what we provide in our own hub, and she gives us more hours than she's actually paid for. But we're just absolutely chock-a-block. And the citizens' advice service in the surgery, that's now finished for whatever reason. And it's an area of real concern. So I don't know whether they have funding from exterior sources and how we can actually bring that in more effectively, because for the last 3 years we've had to fund the citizens advice service ourselves through fundraising, but I don't know how sustainable that is, and I just wonder how we look at citizens advice going forward. And my final thing really is to say there is no two ways about it. The surveys that we do show that the number of food bank users are going down in our area because they are now in a more sustainable and we're looking at all sorts of preventative measures. So that definitely does work. But I am a bit concerned about citizens' advice, so I don't know how we.
Citizens' advice.
Yes.
Are funded by parish councils.
They're not funded by our town council. I mean, in any shape or form.
So my parish council does. I think Coal Hill does. So
Report.
yeah. So maybe that's a question to take back locally.
So outside of this paper, my team also do manage the contract we have for information, advice and guidance, which is the advice hold. So that does fund. It's like it's a core funding, so it enables them to open their doors, offer information, advice and guidance to the whole of Dorset Council area. And as part of the contract we put in, granted it was at the end of 2020 now, they had to be in places of need. So they have moved away from having their main office space. So they have still got that, but not as many, to be in a lot more places.
Yeah.
It obviously a lot has moved in those 5 years. So the grant the contract we give them doesn't cover all of their costs. They do have additional programs from all different sources as well, and of course to help things like the debt advice, the more specialist advice, that's where the cost of living money comes in, and that's really important, because obviously they do run a lot on volunteers, but they also, for the specialist advice like debt management, they are paid roles. And then they're not cheap because they're very specialist. But the demand that since COVID that has gone up very much is around those debt and caseworkers. And that, I think, going forward for the Crisis Resilience Fund, the National Government Policy Officers were very much talking about that kind of work. Moving it to prevention, but education as well on money management, budget supports. So they are, it is all balancing out. Their need, there has increased significantly year on year.
Yeah.
And a separate piece of work we are doing at the moment, which will come through the committee process in the next few months, is at how we support and fund the voluntary sector from a core point of view. So this is outside of this cost of living, and in that will be how we fund things like information, advice and guidance, also infrastructure for the voluntary sector, grant funding and commissions. So there's a big piece of work which I know a lot of people have fed into to gather the research that we need from the sector to tell us what you need, which we're now reviewing, and we'll be working with the key people from the sector to help develop a new model, like I said, which will come through our cabinet process going forward.
I think if it's at all possible to look at all of our housing associations. So for example, SNG are very good. They have a whole array of help, but we go to somebody like Asda or Magna or Places for People, they don't. And I think actually if we could pull them all together, they could do a lot more than is currently being done.
So as part of the review, we have actually spoken to the 5 main housing associations that cover the Dorset Council area. And as you said, because they're all individual, some do a lot more than others, and they prioritise differently. But I think we are quite reassured that most of them do give a good amount of support, because some of them are quite small. But yeah, so they do support that. And of course the other thing as well with citizens advice is some of the town and parishes will choose to fund them, not all, but of course that's a decision that each town and parish will make through their committees. So
okay. So Bridget and Andy, I do want to try and move this on a little bit, because our next speaker The next paper is on a timeline.
Oh.
So if we can speed up a little bit, Bridget.
Just quickly to say, I think in Bridport we support CAB through service level agreements.
Yeah, Bridport Town Council do have an SLA with them as well.
Yeah, my question was just on from your question about whether people pay this money back, the crisis funding. My question is, how many people have received that support and then go on to reapply more times? Do you have data on that?
I don't
Is
know.
there a limit to how many times they can apply?
So
Well,
I caught up with Tina Frampton this morning just to ask, because they weren't able, like I said, they weren't able to be at the meeting today. I think it very much depends on the individual circumstances. So when they currently for the discretionary housing payment, when they make an award, they make it for a 3 or 6 month period. Now, for some people, that's fine, and that's enough to get them back onto be able to pay. So, for example, if they may have unfortunately lost their job and then they've got a new job starting, so they just need a little bit of help for that period. We have got other families, for example, where there may be additional needs. If the home has been specially adapted for disability, and the landlord puts the rent up continuously, then they may be with us for a much longer time. And of course, separately to this, but very much connected to, with the new renters reform bill coming in, it will prevent some of that from happening. But obviously, I'm not an expert in housing, so. But yeah, so like I said, some people are with us for a short period of time and need the support. Some people need it for ongoing.
Okay.
Sorry.
But I didn't really answer the question. How many people have reapply?
What, for the same thing?
Yeah, for the same.
I would have to, the revenue benefits team would need to come back on that for you, but I can find out and come back.
And is there a restriction on the number of times they can apply? Without some form of education?
Absolutely. So, I mean, I would see, going forward, we'd be working much closer with our housing teams and our revenue benefits teams through the new CRF fund, where the government are bringing it together to kind of make sure that picture's a lot more joined up. So I would anticipate going forward, we'll be definitely making improvements in that area. But as far as the actual statistics are concerned, I'll have to come back to you.
Okay, thank you.
Thank you. Andy, you've been very patient.
Very quick, very easy one for you. Is it possible for us to get insight or a report on which parishes do step up and contribute to these discretionary spends and which don't?
Specifically for citizens' advice?
Citizens' advice, Dorset Community Transport, any of those sorts of things. There's a big conversation at the moment going on about what's devolved down to parish and town council levels. I'd be interested to know what we're already doing and what gaps there might be.
Yes, citizens' advice is relatively easy for me because we have a large contract with them, so they're quite easy. They can give us the data. Regarding the transport, I think we probably could. It may take a little bit longer because we have to speak to everybody individually.
If I may, I'd be quite concerned about that actually, because the parishes and the towns, they're all different shapes and sizes, some very tiny ones, some large ones, and I think that kind of
Not a shaming
discussion
exercise.
would be. I'm not sure that how that would benefit, and those who are not contributing are not able to contribute.
I think a conversation alongside the scale of the precept that they're able to claim puts it into context as well. But more importantly, it's a suggestion as to where the gaps in provision are. It's all very easy for us, as say those of us who live in areas that can charge hundreds of pounds in precepts, to provide additional services like that and look good in the process, and then still drop 50 grand on a playground.
It's a much larger conversation around a policy and overview. I'm not sure I get where you're coming from, but I think it's a bigger question for.
It might be that we include that as part of the communities for all development work that we're doing. It's a council priority.
Let's bring Ryan in. Sorry.
Yeah, thank you very much. Laura's just touched on that. It's something we can look at with the communities for all partnerships we're doing, and around the devolution. So picking up on a couple of points today, some of these programs are examples of what we can flow down as ways that town and parishes can become more involved as we devolve powers down to them and supporting more locally in their area. So we can take that comment forward and consider it as part of the Communities for All.
Thank you very much. I
Thanks,
think we're happy
Renee.
with that. Okay, so the recommendation is typed correctly on this one. Is to review and comment on the progress of the investment in preventative and reactive spend. I think we've achieved that. And the second bit was about the household support fund being phased out and the CRF. I think you gave us a very good update on that. And obviously, I think as we go forward, we want to hear more, even if it's just a quick update outside of meetings by email to say how things are progressing. I think the members of the committee would appreciate that.
So we have a small task and finish group currently looking at the development of that. Obviously, we've got limited information at the moment, but one of the key things we did put on there was as soon as we have more detail to be able to do a members webinar, so that to give information and obviously help develop that fund.
That would be very helpful. Thank you. Thank you, Laura. Thank you, Ryan. Okay, I'm going to move us on now to the Safeguarding Adults Board annual report. And we have very patiently got Sean Walker McAllister, and thank you very much for coming into the meeting so early. I know you've had a very long wait.
Thank you very much. Thank you. So members will have had the opportunity to read the annual report. So I don't intend to do a long presentation or the report is actually in presentation format because we wanted to make it accessible to everybody and clear and to enable people in different organisations to use that presentation format in their own boards of trustees and boards to showcase the work we've done. I'll just start by saying a little bit about your Safeguarding Adults Board in Dorset. So I've been the independent chair of the board for the last nearly 4 years now, actually, and I'm independent of both Dorset Council and BCP Council because we have two separate boards, but we meet together. And we share subgroups and we share policies and procedures. Importantly, because all of our statutory partners work across both local authority areas. So this is an efficient way of working and enables us to ensure that people are less likely to fall through gaps between either of the local authorities when working or when coming into a service via one of our statutory partners. So the Care Act set out responsibilities, section 42 to 45, that each local authority should have a Safeguarding Adults Board. And Dorset Council has chosen to appoint an independent chair to hold both the council to account and the other strategic partners working together as a partnership. We have a few statutory duties. The first of those is to publish a strategic plan. They're usually published for a 3-year process, as most strategic plans, so they roll forward. The second statutory duty is to produce an annual report, which sets out how in the previous year the board and its partners has delivered against the annual strategic plan. The third duty is during all times of our operation to have the relevant governance in place to commission statutory safeguarding adults reviews. And those are when an adult with care and support needs dies in the area of the board or suffers significant harm, and where 2 or more agencies failed to work together in a way that might have prevented that death or prevented that harm. Statutory safeguarding adult reviews are not about apportioning blame. They often exist alongside other statutory reviews, but my approach to those is that we work efficiently. So in this year, and you'll note in the report, I've set up protocol with Her Majesty's Coroner for Dorset, and we keep each other regularly informed of coroner's inquests or reviews that my board is intending to commission. We work with NHS England on the statutory mental health homicide reviews. We work with the Dorset Community Safety Partnership also around domestic homicide reviews. And my way of working is that I don't believe we should, even though a review, a domestic homicide review, for example, might meet the criteria for a safeguarding adults review, I see very little point in undertaking a second bash at it through having a second statutory review. So through the board, I always ensure that the relevant people and usually within adult social care, which is the lead statutory partner in the local authority, works with the community safety partnership to ensure that the terms of reference include any key line of inquiry that we might have wished to pursue were we to solely commission a safeguarding adult review. We receive all those other statutory reviews where they concern an adult who meets the safeguarding criteria in our area back at board, and we will oversee, as well as the other statutory partnerships, delivery of actions against the plans in the same way as we would oversee delivery of actions for a safeguarding adult review. Having said all of that, in this last year, which only goes up to the 31st of March 2025, and I know that seems a long time ago, but we co-produced the report with our partners, and it goes to the board annually in September, hence my coming to you at this time of year. We haven't commissioned any safeguarding adult reviews specifically, or published rather safeguarding adult reviews specifically in that time period for Dorset. There are reviews ongoing at the moment, and at the next annual report publication this time next year, there will be a synopsis of those safeguarding adult reviews if there is a decision to publish. Well, there'll be a synopsis anyway, but we may or may not decide to publish. And they will also be contained if we publish on our board website. You'll see from the report that we've undertaken a significant amount of work, and key to our work is our partnership. And I'd like to give you two pieces of evidence of how the partnership works together. The purpose of the board and members in when I was listening to earlier reports today talked about prevention and have talked about outcomes. The purpose of the board is to prevent safeguarding incidences recurring, and to learn together, to work together, to have the same aims and the same understanding. We have joint policies and procedures, as Councillor Kippax will know, because he was involved with us many years ago in BCP when we worked to develop those policies and procedures. And it's really important that that the board is used. It's a strategic board, not an operational board, but it's used to highlight areas of concerns so that as a board we can seek assurance that the right processes, the right governance is in place to make sure that we can evidence working together in a preventative way. Two examples I'd like to highlight. In the last week, I received contact from Dorset Police and their vulnerable people's partnership board to go and talk to that board about the work of the Safeguarding Adult Board, thus enhancing some of the work we do and some of the understanding. Our strategic plan, which is set out within this annual report as well, has a sort of key underlying theme, and it's communicate, communicate, and communicate again. And we work with many groups and partners to ensure that there's a wide understanding of what safeguarding adults with care and support needs means and how we can work together more preventatively. So the work I'm doing with the Police Vulnerability Partnership Board is really, really important. We've got an excellent relationship with the Community Safety Partnership in Dorset, and we're re-establishing our relationship with the Children's Safeguarding Partnership as well. There were examples given earlier when you received your report on carers and young carers around Think Family. And Think Family is very much part of our strategy. So we expect and hold adult social care in Dorset to account for working in a way that evidences and demonstrates Think Family. So if there's an adult with care and support needs that receives a safeguarding intervention, if there are other members of the family that may be affected, such as a child or a young person, then we expect to receive assurance and that the relevant authorities and the relevant organisations that support and ensure safety of children are taken into account as well. Another example of evidence, and this is this year, so I guess I'm using a bit of kind of chair's license here, of how the board and its subgroups affect improvements in practice. We established in the year of this annual report a subgroup of the board on the Mental Capacity Act and the deprivation of liberty safeguards, and they are two areas where we've learned from safeguarding adult reviews and where we've learned from our deep dive into practice that there needs to be a greater focus. And arising out of that greater focus, that subgroup is chaired by the Director of Adult Social Services for BCP, Betty Butlin. Arising out of that focus has been agreement on delivery of a memorandum of understanding across all our NHS provider partners and NHS Dorset to ensure that when discharging people from hospitals, so again, an area that you were looking at in earlier reports, due consideration is given to deprivation of liberty if perhaps somebody needs to be detained because their onward destination isn't safe for them, or they need to have a little more time before something is being sorted out. Now, I'm very mindful of delayed transfers of care in hospitals, having I'm an independent consultant as well, and that's an area of my kind of work and expertise. And I know that we need to facilitate that happening, and that's why we have that memorandum of understanding. So it's absolutely crystal clear where, if there is any confusion, how a situation, a person's situation might be escalated so that services are delivered in accordance with the law, and we can seek assurance that all partners are working together to deliver what we need to deliver. Perhaps I won't say any more. There is data in the report. Having said that, data in the report, just a page in the report on data on adult safeguarding in Dorset. There has been an increase in concerns. Section 42(1) of the Care Act talks about referring safeguarding concerns, and we will expect that the majority of those concerns will be resolved at the point of access. And I feel absolutely assured that Dorset has got it right, because having experienced some delays in past years, as of 5th of November, there was only one case waiting to have triage, and that was resolved the next day. So all the safeguarding concerns that are referred are triaged on the same day. They usually will go on to a referral to a voluntary community sector agency, another support agency, to provide the support nearest to the person's home and where it's the best way of providing support. It may be that a Care Act assessment is needed, and about 10% of those referrals go on to need a safeguarding inquiry in order to determine the safeguarding outcomes. So I feel very assured, as the independent chair, that Dorset Council is delivering that which it needs to deliver. And for your assurance as members, I meet annually, sometimes a bit more than that, with the chief executive, and I meet every 6 weeks with Jonathan Price to talk about any concerns I have. And so I have the opportunity to raise issues where I think more work needs to be done. I would say at this point in time, and certainly over the last year, I haven't needed to raise any concerns, because I felt the cooperation I receive from adult social care within Dorset Council is excellent. And I have been chairing safeguarding adult boards for about 11 years now, so I know what it's like in many other local authorities as well. and I continue to work productively, cooperatively and proactively with officers in the council. And that's all I'd like to say. Thank you.
Thank you very much. I think you've made Jonathan blush. Very kind words indeed. The report in detail was looked at by a subgroup composing of Sally and Carl before this meeting. Would you guys like to give us some feedback on what you've been doing?
Yeah, I mean, it was a good meeting. The report is very, very detailed. So there's a lot to read through. During the meeting, we did cover quite a range of topics. There's discussion about the work with prisons that they've been doing to kind of improve or reduce reoffending rates and things like that, and how they're working with other organizations to kind of get that all worked out, basically. And then there was even like some conversation about GDPR and its application, and how some people within their partnership group don't necessarily have the same interpretations, and how that can cause tensions between the different working groups. But overall, it was a very positive report, I would say. Sally?
I think one of the useful things was actually, whilst we had the increasing number of safeguarding concerns reported, many of those were highlighted as not being actually safeguarding, and they could be referred back to GPs and to other organisations. But it's good that people are actually feeling confident that they can report something if they're not happy, and then actually that it can be diverted to the correct place in order to get sorted out. And I think that, you know, long may that continue, that it's, I'm not saying it's not our problem, but actually they can be sorted out at a different level, which can be really quite important in that respect. So we're expecting to maybe have some SARS next year for us to look at. We didn't have any this year, but that's a good thing. And as you said, we identified that the board is sort of really looking at self-neglect and hoarding as an issue, particularly that around those aspects for adults that they're within their homes, etc. I think the prison work sounded particularly good, because so many people come out of prison and then they're just straight back in because there is nothing out there to look after, and they're actually very vulnerable people. So to actually be able to ensure that they, you know, they've got somewhere to go and they've got a good exit route is really very good at that stage. And again, it was noted that the board has its own complaints procedure, and that very often the complaints that come through are not about the services from the board, but from other places. So again, are passed to the correct place in that respect. So another thing we raised, because we've got quite a large boundary area as well, is when we have the out of county placements, etc. But very often those are due to necessity because of where the patient actually, where the resident actually lives, and it might be that actually their nearest home or their nearest care home is over the border, as opposed to being in Dorchester. You know, if you live in North Dorset or around there, then that's often a better place in that respect. But it was a really useful meeting, and it was I think that's really the board and also the adult safeguarding really should be commended for the work they're doing, because yeah, they're making a big difference to our residents. Long may it continue. Yeah. Thank you very much.
Jonathan, is there anything you wanted to add?
No, I think it's a really full report, and it sounds like you've certainly been through all of that. So it's great to have Sean in the system, and you know, continuing to take this role forward for the years to come. So thank you very much for the report.
I've just got one question on the SAR on Simon. When we heard about it last year, about his transfer from Scotland down into Dorset, and you know, the unhappy ending of his story, and there was talk about, with the action plan, about making changes in the way different authorities talk to each other about doing those cross-boundary transfers. I mean, I know his was an extreme case because it was Scotland rather than just a local one. But where are we on that journey? Are we actually seeing improvements now?
So perhaps Karen, may I come in first on that? Because one of the actions was to raise nationally that the issue with the Department of Health and Social Care. So I helped coordinate the National Safeguarding Adult Board Chairs Network, and worked on the escalation procedures to enable that to happen with the Department of Health and Social Care. And we have escalated that as an issue because it would require some primary legislation change. So it's not going to, that's not going to happen quickly. But DHSC are yet to come back to us on what they propose in terms of kind of guidance or regulation to urge people to not only across countries in the UK, but across county boundaries as well, to make sure that records transfer. And I think that, you know, whilst we can't enforce that from a statutory perspective at the moment, what SAR Simon enabled us to do was to think, to put in our conscious competence that we always need to think out of the box if somebody has moved from elsewhere. So we need to be, you know, finding out where they came from and then checking with that local authority, with the NHS in that area, what the pre-story was, what was going on before, in order to have a better understanding. And so SAR Simon very helpfully enabled us to raise that as an issue across both Dorset and BCP and nationally, because it was escalated nationally. And I think people are much more alert to that as an issue now. On the issue of out of county placements, if you like, where as a sub chair I need to be most concerned is on out of county hospital placements, where people with incredibly complex needs are placed in specialist facilities, and you wouldn't expect every single local authority in England to have a specialist facility. So we know that there'll be people placed in Norfolk or Hertfordshire or Devon even. And that's where on the March agenda of board coming forward, I'm asking for information both from Adult Social Care and from NHS Dorset to enable me to scrutinise what is actually being done with people who are placed out of county. How are they being supported? How are they being reviewed? How are their family members being listened to and supported to support the person? And importantly, what plans are being made, if plans are appropriate for them to move back into Dorset. So that's a question that will be asked, and which I'll be scrutinising at our March board. Sorry, I used a bit of chair's licence to expand on that, but I thought it might be quite useful for you to know.
Chair's licence as well. I'm glad that you're going to be taking on that scrutiny, and I'm just wondering whether, when you've done that piece of work, rather than waiting for the next annual report, whether you could field something to us so that if there's anything that Dorset Council can do better, that we can start to put that into train and scrutinise that action plan.
I'd be happy to share my briefing on that. It will be a briefing, it won't be a full-length report, but I'll be happy to do that in post-April.
Yeah, that would be absolutely fine. I think it's important enough. Make sure we get that right. Does anyone else have any comments? Thank you very much for coming again today, Sian.
Thank you. Always a pleasure. Thank you. Enjoy the rest of your meeting. Bye-bye now.
Okay, we're almost there, guys. And item 12 is the Q1 performance report. Thank you, Rob, at the table.
Sir, okay. Okay. Oh, I'm after breakfast, Jen. No, don't worry. No, don't worry. It's from
No, that's not. Thank you, Rob. You can all come to the table if you like. We don't mind, I promise. Oh. So we have quite a few people with 2 o'clock deadlines on all sides of the room, so we will crack on without further ado. Chris, you're going to take us through the report.
Yeah, absolutely. Good afternoon, Chris Highway, Strategic Performance and Risk Lead. This performance report builds on the Q4 position you received on the 30th of July and marks an important milestone. This is the first full committee using the new Scrutiny performance dashboard. Dashboard is designed to strengthen transparency, improve strategic alignment, and enable members to interrogate the data in real time. This report provides an overview of key performance trajectories and exceptions, as well as the red and amber and worsening indicators with contextual narrative to support the data. Furthermore, Q1 marks the first time that strategic risks have been incorporated within the committee's performance report, recognising the important interplay between risk and performance. Moving into key developments and actions. Since the meeting on the 30th of July, we have launched the aforementioned new Scrutiny performance dashboard, which is publicly accessible and incorporates historic trend data alongside 2025 and 2026 Q1 figures, enabling members to track changes over time. Part of the implementation has included training and support for committee members to ensure confidence in interpreting the data, as well as in utilising the dashboard to help identify emerging trends to inform evidence-based decision-making. As a point for the record, there are no actions from the Q4 meeting being carried over. So moving into the performance focus areas and performance indicators, the Q1 performance overview is available via the dashboard and also included in the report with supporting narrative provided in appendices 1 and 2. Appendix 1 provides red rated indicators accompanied by the narrative, as well as Appendix 2 has the amber and direction of travel indicators. From these, a number of performance areas have been highlighted for additional focus at committee today. These areas are detailed in the report at paragraph 4.5, with 4 indicators relating to adult social care and to children's services. So introducing adult social care firstly, the information relating to these areas is detailed in the report from paragraphs 4.6, 4.22. I'll take the information as read, if I may, Chair, and hand back for comments and questions relating to those areas of focus.
Do members have any questions on the performance of adult social care?
Wait, haven't we done that instead? Poor Julian needs to go and lie down.
Good job putting this at the end.
Yeah, I think a 3-hour grilling earlier this morning is probably.
We shall move on.
Okay, we should move on.
Happily move on to the information related to children's service areas of focus, and that's in the from paragraphs 4.23 through to 4.31. And again, I'll take the information and back for questions or comments.
Okay, children's services.
Children's services, right? Okay.
Carl.
Yeah, thank you. Carl Wood, Councillor Carl Wood, Gillingham Ward. When it comes to the EHCP stuff, I'm looking at the percentages, and I thought the North was quite bad, but then I saw East and Purbeck is even worse. One of the things that is indicated in the report as a pathway to improving this is strengthening staffing numbers and things like that. So I'm curious, what are the numbers, and are they full-time, all full-time, or are they part-time? Who's actually carrying this stuff out?
So Paul Dempsey, Executive Director of Children's Services. We're initially full-time staff, but there are part-time staff. The caseloads recently in this period have gone up because you'll see partly the report is telling you that need and demand has gone up. There is an increasing number of requests for education, health and care assessments, and following that, education and EHCP plans. We did put extra capacity in to try and deal with that in the sort of Q1 and Q2, towards the end of Q1. So an extra 6 temporary staff were put in place to try to manage that increased workload. They're still in place, those temporary staff, and we have a plan now. We're reviewing our staffing capacity and our model for delivery, and in proposals are plans to increase capacity to support those staff who are doing the working with those children, doing the assessments and delivering the plan. So we recognise we need more capacity, and we're trying to address that. I think, I'm not sure if the report says it, but we're also looking at whether we might be able to make efficiencies through the use of artificial intelligence. We know that other local authorities are using that to make efficiencies when they're bringing different professional reports together to make up the final patient health and care plan for young. So looking at increasing capacity in staff and the sensible use of artificial intelligence to make efficiencies. But yeah, the increase in demand or need does reflect the national condition for the last few years, and our need has grown a bit faster. So yeah, that's where we're at.
Because it does seem that EHCPs are a regular offender in terms of these performance scrutiny meetings. Is there something inherent in what the process is that's causing that? I mean, there has to be something more than just we need more people, is it?
One thing is need, demand. Second thing is that it's a partnership sort of approach, so it's not just us in the local authority. And of particular difficulty over the last 6 months is that we've introduced a new electronic sort of recording and system. It's not fully in place. Well, it is in place, but it's not fully working and delivering what it's supposed to be delivering at a minute. So we've had to really do the accounting in the last 6 months manually. We haven't got it reporting properly. We do think actually that we might be under-reporting performance. So machines, the systems not counting all the plans that are delivered on time, in time. So performance we think might actually be better than what we're reporting here today. So we have raised it as a risk that the system isn't performing as it should yet, and we're working with our colleagues across the council to fix that.
Okay.
So you are aware that we are doing a deeper dive into EHCPs. Jane and Bridget are on that. The review is taking longer than we'd hoped, just because it's a big subject. Trying to coordinate diaries and everything is making it difficult, but we're hoping that we're landing some more dates soon, so that we were able to bring it to hopefully a happy conclusion.
Yeah.
Jane, you wanted to say something?
Yes, thank you very much. Thank you very much. We appreciate the difficulties you're facing in the service. I just wanted to ask you about reviews, because clearly there's a issue there too, which is they're kind of interlinked. And I just wondered around what you are doing around priority recovery actions to prevent drift for children, and how you prioritise that.
Yeah, so by explanation, one of the challenges that has grown over the last 6 months has been increasingly being asked to make amendments at reviews. So making more amendments now at the request of schools, where schools more often are saying we can't meet this child's needs without such and such support. So that has escalated. So that takes more time and capacity. So similar to the answer to the first question, is a demand and a need and a capacity problem, which we're trying to address, firstly by temporary staff coming in, secondly by amending our model, our staffing sort of model. That's where we're at.
Yeah.
Demand,
yeah.
Capacity
Yeah.
increases, demand for requests has gone up.
Yeah.
In the review space, there are more numbers anyway, because there's more, and also more to review. But the reviews themselves, more of them are taking more time because of requests for amendments.
Okay. Okay. I'm not going to ask you to look into the future. But the changes coming through around the requirement for schools to step up
Yeah, that's a good signpost.
Yeah.
We are looking for reform. We were sort of more or less promised reform, or a paper would be published about now. Autumn was the time. It's been delayed until at least the new year. I don't know whether the new year means January or June. Will be. It won't be. So
It's not helpful to you though in your service.
it's not helpful to us. We're really excited about reform because reform is needed. We can't do everything we need to do to make the system work locally on our own. So, and the government is looking at reform. I think that acknowledges that there is a national recognition that the system nationally doesn't work in a way that is financially sustainable or in a way that improves outcomes, especially for children. Nationally, outcomes are said to have not improved since 2014. But I would like to take the opportunity to say really positively that education outcomes for children in Dorset on education, health and care plans have increased significantly over the last year. And if I'm going to my notes, I'll be able to tell you almost exactly at Key Stage 2 for reading, there was an increase in our children on the HCPs reaching expected standard of 9%. In writing, there was an increase for our children on the HCPs reaching the expected standard of 8%. And in maths, there was an increase of 9%. And in all those three subject areas, we're 1% above the national average.
That's excellent.
And in Key Stage 4, for maths, scoring 5+, we increased by 1% this year compared to last year, and we're 1% above the national performance. And in English, 5+, we're 2% above national, and we had a 2% increase over the last year. So whilst we're not happy with our position on time and HCPs, we're very happy that children succeeded well.
That's a really positive trajectory.
Yeah.
Can I add just one, if you wouldn't mind? I'm Jen Fennell. I'm the Corporate Director for Education and Learning. In terms of both the outcomes and also the reviews, we're doing a lot of work with our SENCOs, so the leads in our schools for special educational needs. Usually they are the professional that will be leading the review process. So we've been giving them some training and support so that they can carry that out efficiently and effectively. And I think also the training that we do with them around inclusion for our young people, I think that's been reflected in the outcomes as well. It's really high engagement with our schools and other professionals. So, you know, it's a positive position from that as well.
Really is good news to hear.
Yeah.
Okay. Do you have any more questions, Carol?
Sorry, thank you. With regards to the children coming into care, which increased over Q1, is there, I'm just trying to look at how we can sort of get more in front of the curve. And I know you do a lot of work in that respect, but what is how much work are you doing with the families before you actually take the decision? Or is there anything that comes to mind? Is there a certain age group of child that the parents aren't coping with in any shape or form? Or I'm just trying to see whether there's anything we can do more in the community to work with these families in the hubs to try and stop that. I don't know if I explained it well enough, but you got it, Paul.
Yeah. So we are doing a lot to support families to stay together and to manage our children in care population. So the Family Hub programme is part of that. The Families First sort of programme that we've been a pathfinder for is all about prevention and partnership work. We have our outreach service from the Harbour that works with adolescents on the edge of care, and those things were really successful in sort of 2020 and about January 2025, and the population of children in care started to go up actually from January. It's now since August started to go down, so we've reduced our population by about 15 or 16 children since August. I haven't got a crystal ball, but you know, all the things I just said, I think are the right things to be doing. I anticipate our children in care population reducing further as we continue to do all the right things. It's not a promise, as I say, I haven't got a crystal ball. And I do know that children in care population is going up nationally, and there are lots of sort of pressures that potentially create that. And I do know data is telling us that the number of children on a child protection plan is significantly lower than it was. So normally children's journey to entering care is via being on a child protection plan. And we now have about 60 fewer children on a child protection plan than we did in February 2025. So we are supporting families to be safe and to prosper and promote the well-being of children without needing to put as many children on a child protection plan. And our children in care population at the moment, since August, is coming down again. So I think we're doing all the right things. We'll continue to look at supporting families as early as we can and investing in prevention and partnership services.
I'm just wondering whether there's an opportunity to sort of share information in any shape or form, so that if you identify a family, say in North Dorset, that you think could possibly be at risk at some time, whether if we worked with them at the hub, what could we do with them as well to help prevent that? But I don't think that information is being shared in any way, probably not supposed to, and all the rest of it. But actually, I think a joined up approach could really work.
Yeah, where parents consent.
Yeah,
you know,
yeah,
can do things. Yeah,
I think maybe this is a conversation you could, if it's particular to hub that you're involved.
Well, it could be any family hub. It could be anywhere, couldn't it? Any children's centre, any family hub, but it's sharing that information.
But I think as a start, perhaps have a more detailed conversation outside of this meeting.
Yes, just in the report, just a reference to the percentage of 16 and 17-year-olds not in education, employment or training, specifically around the issues in Purbeck, where it appears from the report anyway that the active provision not being taken up in the way in which you want, and that may well be because of difficulties actually in transport, basically, and not being able to get to the provision, and the suggestion that without some intervention it could hinder progress and increase disengagement unless there's something more flexible, more localized. And I mean it's just highlighted here in Purbeck. I don't know if that's repeated in other areas where access is challenging, and what, if anything, it can be or what you're doing to address that.
Well, we know that transport is often an issue.
We've touched on it already today in other areas, so it's not unique to this.
So I haven't got a brilliant answer to this question, so I wasn't prepared. I was only prepared to revise, answer questions and prepare for the EHCP questions, but I'll certainly take that away and come back with an answer to you about that.
No, it's fine. It's there. It's in the report. So. Apologies. Sally.
I just want to ask a really quick question. Probably isn't quick. It's going to be short. Is the percentage of children needing EHCPs increasing against the children's population as a whole?
Yes.
Yeah. I thought you probably was. There you go. I thought it was easy. There you go.
And that's locally and nationally.
Yeah, I was going to say it seems to be it's quite a big trend, isn't it?
Andy.
Two very quick ones. How are we doing on early diagnosis? So what is the average age of men or boys or girls being diagnosed as requiring assistance changing? So is it getting earlier, or is it getting later, or it's staying the same? And how, second and different, how is the relationship with academy trusts with regards to training in being send aware going? Because I was aware that a couple of years ago it was suboptimal and that some work has been done in order to bring them back to speed. I'm just interested to know how that's progressing.
So on the first question about diagnosis, so don't know the answer to that question, and I'll talk about identification of need instead, I suppose, because we're working very hard to identify need as early as we can. The Value in Send programme that we were running in partnership with Empower was focused on working with early years settings to support early years settings to identify need in children as early as possible, to train the staff in early years provision to meet that need, to work with parents to provide reassurance and confidence to the parent about their child in the early years setting, and also to do school readiness work with the staff at the receiving primary schools, and that's worked really well. So our strategy is about identifying need early, giving staff the confidence to meet that need without necessarily requiring official diagnosis or specialist.
Forgive me, that's my fault for using the wrong language. I used the language of a layman. I equate the words being the same, but you're absolutely right. It's need.
And the second question
was about academy trusts and training up staff within them in order to be SEND aware and EHCP aware.
So we've had academies regularly. We've got a round table with academies now. The DfE is supporting us with that work, and the relationships are growing and improving. I don't know from years ago what the relationships were like because I wasn't here, but relationships are working well, and we're all working together to try and improve outcomes for our children. If you got any further, no. It's very new, so it's getting used to our system. But most academies working reasonably well.
So the Senkos can obviously attend the training as well, so that's not reserved for our maintained schools.
No, I'm fine. No, I asked the wrong question. It's been a long meeting. It doesn't matter. I'll take it up with you around. It's fine.
Bridget.
Mine's just a quick comment that for Andy and everybody else, that the VSEND is very, very popular. And I know from Dorset Education Board recently that the numbers of early year settings and schools applying to actually do the VSEND is increasing, isn't it? I think it's gone up. It's gone up quite substantially. The longer it's in place, the more popular it's becoming, because schools are really finding that early support being put in place, and particularly working with parents who are often the drivers for these EHCs, are actually being much more reassured that schools can manage the support their child needs through that VSEND.
It would be really that we have high take-up of early years provision in Dorset. And in terms of early intervention, their needs being picked up in their early years setting is really important. And then, as I think you were alluding to then, if those conversations are taking place in the early years with parents, with partners, with both the nursery and the receiving school, there's a very good chance that needs can be met without having to go through the EHCP process. And also that needs won't escalate up because we're getting in there early. Yeah. So, that's really about preventing those children becoming a statistic while still meeting their needs. Really good news.
Good. I'm just going to very quickly pick up on page 51. You've got the indicated percentage of looked after children placed outside the council area, and it's come up as amber and worsening, and yet the narrative says that there's been a slight decrease in the number of percentage of children living outside of the doors at the end of Q1 compared to Q4 last year. And the narrative doesn't quite fit with the frag rating.
Yeah.
That looks like an error. I think you should put it on that one, Paul.
That corresponds with the time of our children in care population went up. Some of those young people were placed outside the authority. up to 2 children in care population. And positively, our fostering services looking after significantly more children than they were.
Sorry, Liz. You want to take us, Chris, you want to take us through the risks? At the end of the report?
Yeah, I was going to highlight committee monitors 18 strategic reports. The dashboard presents all of these risks with detail, and in the report we've tried to cover off the very high or the high. We have one worsening high risk, which is the application of NHS England, as to improving high risks in the report.
You have to speak up, Chris, they can't hear you.
Sorry. So the People and Health Committee currently monitors 18 strategic risks. The dashboard presents all of these, while the report provides essential context regarding any changes in risk ratings, the factors influencing their movement from risk rated very high or high. We have one worsening high risk detailed in the report, as well as 2 improving high risks. You can take any questions, fill them where we can, or take it away.
Any questions on risks? You got away with that one. Yeah. Okay, so recommendations are that we note the performance overview and consider the triangulated analysis for the identified areas of performance focus to inform actions and recommendations. You've been doing that all morning, haven't you? Right. So, I think we've met those recommendations today, so thank you both very much.
Thank you.
So I'm going to move us on now to the last agenda item, as we have no exempt business either, and that's the forward plan. Very quickly, find my correct piece of paper. On there, yeah. So we were interested moving forward into having the Help and Care Young Carer, the new service, sort of an interim report after about 6 months, which would be sometime next summer. And then possibly a wider discussion on reablement. Yeah, some of the things that came out of this morning. Was there anything else that anybody wants to put on the forward plan? While you're thinking about that, I'll just say that our next meeting is the 23rd of January, and that will be our budget meeting. So I'm trying to keep that agenda fairly clear so that we can focus on the detail of the budget.
Chair, do you think there's, I don't know if it's within our remit really, but it's the diagnosis, the long, waiting 2 or 3 years, and where health fits into that, whether it's autism or ADHD. I don't know whether that's anything we can get into. I know it's national, but I know that it causes a huge amount of stress for parents.
Let us finish the EHCP review, because that's one of the things that came up quite clearly when we did our first interview day with all the stakeholders, and it's one of the areas that we want to follow up with the NHS. And we do, I think we've got a meeting date in the diary now, or is it still being sorted? Or
With the NHS?
Yeah.
I don't know, I have to check with George.
Yeah, it's very close to being landed, a date for us to have that. So let us finish the review.
Okay.
If you're still not happy with what comes out of that, then by all means we'll bring it back and yeah. So we've got meeting with parents this Friday. So I'll just park that for a minute.
Okay, it's parked.
Was there anything else that's a burning issue for anyone? Yeah, we can always deal with stuff outside if there's particular issues. You happy with the full plan as it is? Yeah. Okay, then thank you for that. In that case, no exempt business. 12 minutes past 2. Well done. It's a
oh my God.
Deserve a medal and a cup of
I just want coffee here next time.
In future, if
thank you to all the officers as well.
Thank you so much.
Chair.
See you in a minute.
Chair,
Bye. See you in a bit.
to provide coffee, can you at least put whether it's we should